adults have attempted suicide. More than half of people experiencing homelessness have had thoughts of suicide. 20 veterans die by suicide each day. African Americans are 20% more likely to experience serious mental health problems than the general population. And as a community, Latinos are less likely to seek mental health treatment than the general population. We also need to remember that so many of our young people, especially here in the city of Boston, are experiencing trauma, and those services we need to make sure that those services reach them. Boston is leading the city in so many capacities, attracting talent from across the world from all different backgrounds. As a city, we have to ensure that all of our residents have access to comprehensive mental health services, including in our schools, in our workplaces, and throughout our city departments. This includes college students, the LGBTQ community, veterans, and those experiencing homelessness. It is the diverse individuals that make Boston thrive. I look forward to hearing from our panelists who are experts in this work. They will be able to provide testimony about what they see every day in the field. I hope that after the conclusion of this hearing, we can identify the strengths of services that are currently offered in Boston. I also hope that we can identify existing gaps that are leaving some people without access to mental health and suicide prevention services. Today is certainly the start of a very critical conversation, one that has continued throughout some of the other aspects of our work. I would like to recommend or welcome Councillor Ed Flynn, who represents District 2, and ask if he has any opening comments.
Thank you, Councillor Asabi-George, for your Thank you, Councillor Asabi-George, for your leadership on this important subject. It's a subject that impacts almost every segment of the population in Boston. And your work on this and many other issues is really helping the city. I also represent a high concentration of the homeless community in Boston. District 2 has several homeless shelters, and that's an issue that I've been focused on since I've been elected last year. I've also had the opportunity to serve over 20 years in the U.S. Navy and have read and been engaged in the subject of suicide in the military. As we mentioned, several veterans die every day because of suicide. We are doing a lot of great outreach here in the city on that issue, but it's something that's very important that we can do more. One thing I would like to do is learn more from the experts here on the panel. But as a city, as a wealthy city, with the greatest hospitals, colleges, and universities in the world, I would like to see a mental health counselor in every public school in the city of Boston. For a city with such great wealth and great institutions, there's really no reason why we can't have a mental health counselor in every school in the city. I'm not talking about 2 days a week or 2.5 days a week or 3 days a week, 5 days a week throughout the day. So that's something I'm interested in learning about and hearing about. And if we can't do that, we should figure out a way of where we get the revenue to make sure we have a mental health counselor in every school in this city, whether that's through increasing taxes on businesses or other options. But there's really no reason for that at all. So I'm interested in hearing about those issues. I'm hearing about, as Councillor Asabi-George said, LGBTQ youth in our city as well. Again, so I'm here to learn, and it's a subject that's very important to me. We had a cluster of suicides many years ago in South Boston. We have a lot of young people in our community that are dying every day from overdoses, the drug epidemic. So again, I just want to say thank you to the experts here that are doing a lot of great work across our city on this important subject. Thank you.
Thank you, Councillor Flynn. Thank you to the first panel that we have before us. We have 3 panels today. This is the largest. So I think we'll start, if that's okay, with Dr. John Bradley. At this side, if you would introduce yourself, your affiliation, and if you've got a brief statement or something to share with us, that'll be great. And then Dr. Lowe, you'll be next. We'll move down the line.
Yes, thank you, Madam Chairwoman. I'm John Bradley, Chief of Psychiatry and the Acting Director for the Mental Health Service at the VA Boston Healthcare Service. I have some prepared remarks, and then certainly as the panel evolves, be happy to take any questions. On behalf of the VA Boston Healthcare System and veterans of the Commonwealth, I thank you for the opportunity to provide this testimony to the Committee on Homelessness, Mental Health, and Recovery on the subject of mental health resources, de-escalation, and treatment services for suicide prevention in the City of Boston. I'd like to deliver some prepared remarks and leave plenty of time. I hope to share with the committee some of the work the Department of Veterans Affairs is doing to prevent suicide, as well as some of the examples of innovative programs from across the country that are demonstrating promise. I would also like to touch on several interventions that have been shown to reduce the risk of death due to, quote, diseases of desperation, such as substance use disorders, which frequently confound the attribution of unanticipated deaths to suicide, overdose, or accident. To provide some background for the committee, suicide rates have increased 20 to 25% for non-veterans and veterans respectively since 2005. The rate of increase for veterans engaged in VA healthcare was half that of those who weren't. The highest rate of increase for veterans and the general population was for persons aged 18 to 35 at 22%. The suicide risk for male veterans is 1.5 times greater than the general population, and women veterans are at twice the risk to non-veteran women. The reasons for this are many and have to do with military occupational traumatic exposures, occupational illnesses like traumatic brain injury, substance use disorders, economic and vocational hardship, difficulties with post-deployment readjustment, disability, and access to firearms. Here in the Commonwealth, both our veteran and non-veteran suicide rates are lower than the national averages. In 2016, we had 609 total suicides, 68 of whom were veterans. The national age-adjusted suicide rate is 17.5 deaths per 100,000 residents per year. In the Commonwealth, our rate was lower at 11.2. The national veteran suicide rate was 30.1 per 100,000 per year, while that for Massachusetts veterans was 20.2. When comparing state data, the variable suicide rates appear to be most highly correlated with access to firearms. The rate of firearms used in the method of suicide are 48.4% nationally, but 69.4% amongst veterans. In the Commonwealth, those rates are 22.7 for non-veterans and 39.7 for veterans. As has been stated previously, we lose 20 veterans per day in the United States, but only 6 of those veterans are seeking health care within the VA system. The challenge for us is to work with community partners to reach the other 14. As you may know, the Department of Veterans Affairs is the largest and most comprehensive healthcare system in the country. The Veterans Health Administration provides direct care for over 9 million of the 20 million veterans across the country. In addition to health care, the VA, through Veterans Benefits Administration, provides financial, vocational, and educational benefits to millions more veterans. The two arms of the VA are well coordinated to deliver components of a comprehensive suicide prevention strategy. Through the Veterans Benefits Administration, veterans are offered what can be characterized as primary prevention services through transition assistance, vocational and educational training, housing assistance through VA home loans, and the GI Bill. These services are designed to facilitate a seamless and well-supported transition to civilian life after service to the nation. When service members transition successfully into their communities, become well integrated into support systems, and achieve financial and occupational stability within those communities, their risk of maladjustment, substance use disorders, and ultimately suicide is diminished. The Veterans Health Administration serves those veterans who qualify for health care by virtue of the development of health conditions attributable to their service or because of deployment to a theater of combat. Qualified veterans include those who have served honorably, as well as those who may have received other than honorable discharges, who have experienced trauma, sexual assault, or substance use disorders that may have impacted the characterization of their service. The health care provided by the VA is part of the secondary prevention strategy for suicide prevention, in that all veterans are identified as a population at risk for suicide, and providing comprehensive, integrated, coordinated health care reduces the risk of debilitating illness, substance use disorders, and suicide. The VA has a comprehensive, systematic approach to suicide prevention that is integrated from the national to the local level. In addition to the primary and secondary prevention efforts described above, the overarching strategy for suicide prevention is to identify individual veterans who are at high risk for a suicide attempt. I'll describe several components of this strategy. The VA has developed a predictive analytics algorithm to identify veterans thought to be at the top 0.1% risk stratification for unexpected death to include suicide. This program is called ReachVet. It analyzes data from our electronic health record to include healthcare utilization, diagnostic data, prescription patterns, and service needs. Identified veterans are targeted for intensive case management, care coordination, and assessments aimed at reducing the risk factors for suicide. The VA has also developed a universal population screening program aimed at identifying veterans at risk for depression, post-traumatic stress disorder, and suicide. Screening occurs as part of routine primary care, as well as emergency care and certain high-risk specialty care. Veterans who screen positive are referred for more specific and in-depth evaluation of their risk for suicide and offered treatment that targets their specific risk factors. Whenever veterans are identified at high risk for suicide attempt, intensive case management treatment is provided, and extensive case management by suicide prevention coordinators ensures that veterans receive the care they need and are not lost to follow-up. In partnership with the Department of Defense, the VA has developed a comprehensive clinical practice guideline for the evaluation and the management of individuals at risk for suicide. I was fortunate to have served as a co-author for that guideline, and we are pleased to have implemented the principles and best practices of this guideline to help our veterans. We're very fortunate in Boston that our VA is a comprehensive array of integrated services and perhaps the most comprehensive system of care in healthcare today. Boston VA cares for 65,000 veterans, 14,000 of whom are treated for mental illness and substance use disorders. Our mental health service provides the full spectrum of mental health services to include early transition adjustment services, specialty mental health care, outpatient services to include for mood and anxiety disorders, traumatic stress disorders, psychotic disorders, and substance use disorders. In addition, we provide extensive residential substance abuse and early recovery services. We're the regional referral center for acute and subacute psychiatric care, with 124 inpatient beds to treat veterans in acute crisis with mental illness and substance use disorders. Additionally, in partnership with Housing and Urban Development and numerous state, municipal, and community partners, our homelessness program houses and provides treatment for almost 1,000 veterans annually, and also has strong partnerships with the criminal justice system through our Veterans Justice Outreach Program. As substance use disorders play such a prominent role in suicide risk, I'd like to share some of the innovative approaches that VA Boston has developed and has spread nationally to other VAs to target the opioid crisis. Communities around the country have recognized the benefit of making opioid reversal medications more widely available to prevent overdose deaths. Many of those communities have armed their first responders with naloxone kits. We have taken that approach one step further by ensuring that all of our veterans with opioid use disorders are prescribed intranasal naloxone as part of the risk reduction strategy for their recovery. We further wanted to ensure the ready access to naloxone across our entire healthcare system for use by people who may not yet be identified as at risk to have a personal kit. In this pursuit, we've included naloxone inhaler kits in all of our automated external defibrillators, so that non-medically trained bystanders can provide life-saving intervention to those with suspected overdose. This program has been highly successful, with hundreds of lives saved since its inception. One additional promising practice that I'd like to mention is an effort to change the conversation around the risk of suicide associated with firearms. While the Commonwealth has lower rates of firearm ownership than most other states, firearms remain the most common method of suicide for men and women alike. Firearm ownership is twice as likely to result in suicide than a homicide. Yet people who own firearms do so believing that they are providing for their safety and the safety of their families. The New Hampshire Firearms Safety Coalition has developed an innovative program in partnership with gun shops, shooting ranges, that emphasize the culture of gun safety that is embraced by firearms enthusiasts. They call this the 11th commandment of gun safety. This approach serves to normalize the responsible handling of firearms and safety planning in the event of an emotional crisis. It teaches that it is responsible to safely store your firearms off-site in the event of a crisis. This education is provided at the point of sale for firearms, and educational pamphlets are provided. Gun stores, shooting ranges, and some local police departments gladly store firearms during this period of crisis and return them when the person attests that they are well. Strong community partnerships are key to developing a robust network of services to prevent suicide. In response to an extraordinarily high veteran suicide rate, the VA in Arizona partnered with numerous state and county partners to create the Arizona Coalition for Military Families and establish a campaign they call Be Connected. The premise is that a statewide public-private partnership will create a safety net for military families to avert problems before they escalate to a crisis. They created a call center to serve as a crisis response center, as well as a referral center. The partners also developed a resource clearinghouse to link those in need with programs to meet psychosocial needs. They developed a training network for first responders, the veteran services organizations and healthcare systems to identify at-risk individuals and serve as care facilitators. In its first year, thousands of contacts have been made, connecting families in distress with needed services. They, however, do not have a model to estimate how many lives have been saved to date. We're so very fortunate here in Boston to have a wealth of public and private organizations who have worked so well together as part of the tapestry of service for our residents. The VA welcomes any opportunity to forge stronger relationships with organizations represented here today and new collaborators to continue to reduce the suicide rates in our communities. We're thankful for strong relationships with Secretary Urania of the Massachusetts Department of Veteran Services, Veteran Services Organizations, Commissioner Sterling's Boston Department of Veteran Services, VSOs across the Commonwealth, social services agencies, business partners, educational institutions, first responders, best teams, and the best healthcare facilities in the country. We stand poised to work together to solve this problem. And I welcome any questions the committee may have.
Thank you, Dr. Bradley. I think we'll go down and then we'll come back for questions afterwards. And I thought that I'd have my cough under control this morning, but I apologize for that interruption. Dr. Lowe.
Yes, I have a few slides prepared.
Oh, great. Well, while we cue that up, can we just move down maybe, is Nadine there? Great. Oh. Yeah, we'll go, Jenna, if you don't mind, we'll scoot to you while we just get the password because it logged out and it's password protected.
Sure.
So I'll go to Jenna.
I'll start.
Okay, all right.
Good morning, Committee Chair Asabi George, Councilor Flynn. I'm Michael Stratton. I'm a Deputy Superintendent with the Boston Police Department. I'm assigned to the Office of the Police Commissioner. Some of my responsibilities are overseeing the Boston Police Department's efforts at addressing substance use disorder, mental health, and homelessness. Also with me is Jenna Savage, the Deputy Director of Research and Development for the Boston Police Department. I'm going to have Jenna start by talking about suicide prevention and officer wellness, and then I will continue with the rest of our efforts.
Good morning, Chairwoman and Councilor Flynn, and good morning, President Campbell. So this is a great hearing that we're really excited to be here for because the issue of looking at mental health resources and de-escalation and treatment services for suicide prevention is a topic that is very near and dear to the police department's heart. it's very high risk of suicide among officers and first responders, many of whom are veterans. I spoke to our peer support unit and found out that 7 active duty Boston police officers have completed suicide within the last 10 years, with an additional 3 who were retired. And a study by the Rudderman Family Foundation recently found that nationally, more officers and firefighters are known to die from suicide every year than they do in the line of duty. And these are likely numbers that are being underreported. And based on that study, they found that in 2017, 140 police officer suicides and 103 firefighter suicides outnumbered the 129 officers who died in the line of duty and only 93, well, not only 93, but 93 firefighters killed in the line of duty. The high risk for first responders and officers stems from obviously extremely stressful and traumatic job, compounded with the low likelihood of seeking help and the stigma around seeking help for officers, combined with the easy access to firearms. And so this is a really major issue. And for these and many reasons, Commissioner Gross has made officer wellness one of his top priorities, as well as mental health more generally. And so we're going to speak together about the very many efforts the Boston Police Department is making regarding mental health. With respect to the suicide risk among officers, the BPD Peer Support Unit has made suicide prevention as its ultimate goal. The unit is comprised of 5 officers, all trained in group and individual crisis counseling, and it's been recognized as a national model. The unit provides peer-driven, clinically supported assistance to all sworn BPD officers. Among its many components is the Critical Incident Stress Management Team, which includes 50 volunteer officers who are essentially the unit's eyes and ears. They keep an eye out following things like line-of-duty deaths, suicide of a colleague, a serious work-related injury, multi-casualty disaster or terrorism incidents, or significant events involving children, and so many other types of incidents. These 50 officers keep an eye and ear out for officers who might be at high risk for suicide, and they'll report them back to the peer support unit and hopefully be able to reach out to them, and they'll be willing to accept services. The unit also provides a family assistance unit, mental wellness, addiction services. There are 30 clinician hours per week available through the peer support unit, including individual counseling, included by a Harvard-educated psychologist and a licensed social worker. New recruits, which we have a new class starting today, spend 1 full day at the peer support unit, and the unit also meets later with their family members, discussing the signs that they need to look out for in their family members as they go through this process. There's also an in-service training for supervisors when they get promoted in terms of what signs to look out for among the officers that they oversee, as well as among each other. And all of these services come at no cost to officers, no insurance, there's no documentation, and it's offered off-site from headquarters. And all of these components are really important for confidentiality and reducing that stigma and encouraging officers to seek help. So again, this is a major priority for Commissioner Gross, and we intend to do more moving forward. But first, I'm going to move it over to Deputy Stratton.
Mental health training is provided through the Boston Police Academy. It consists of 16 hours of mandated mental health training for all new recruits and 3.5 hours of in-service training for all veteran officers. Some of the things they are trained on are recognizing signs of various mental and cognitive disorders, including mood disorders, anxiety disorders, personality disorders, dementia, substance-related disorders, and trauma, including veterans who may be experiencing PTSD. De-escalation techniques, patience, respect, empathy, active listening, etc. Specific focus on youth and behavioral health, development factors, and youth suicide. Issuing Section 12s, this is a valuable tool if a person is believed to be at risk for suicide or self-harm. Mandated e-learning curriculum on how and when to utilize the best team, that's the Boston Emergency Services team. We're also providing critical incident or crisis intervention training for officers. This is a 40-hour course, and we've trained 55 officers so far. It's a week-long course, and we hope to get more officers through that training. I think we have 30 to 35 spots coming up in March. And that's a valuable training. I've gone to that myself, and it teaches the officers a lot of valuable tools. It includes de-escalation skills, suicide prevention, and officer wellness. Working with Boston Emergency Services team, BEST, out of Boston Medical Center. The BEST is the Boston Area Emergency Services Program. They offer a triad of integrated services, mobile crisis teams, urgent care clinics, and community crisis stabilization units. We employ a co-response model where we actually have some of their clinicians riding in cars with the officers. We currently have 5 of them assigned to several districts throughout the city. And this is a valuable tool because they're in the car with the officers and they respond to all mental health related calls. They get there quicker, they're more effective, and they give the officers alternatives to arrest in dealing with these situations, because a lot of times they result in violence because officers aren't familiar with dealing with a lot of these situations. When you have a trained clinician with you, you have other options to employ to de-escalate, talk a person down, and avoid arrest. And the best team clinicians have a lot of resources for bringing people to service providers to get the services they need. And the best team, the 5 clinicians that we have, are funded through a combination of federal, state, and city money. And we have to thank the City Council Committee on Homelessness, Mental Health, and Recovery for designated funds towards this effort. We have 5 so far. I'd love to get a lot more. My goal is to have a best team clinician in each district on the day shift and at least the first half shift. Some of the valuable things that we get out of the best team is immediate on-scene response, access to mental health history. It provides jail diversion and follow-up. Follow-up is critical. We're working on training all the other officers in the field as well that aren't working with the best team clinicians. If they're familiar with the program and they encounter a call that wasn't designated as mental health but turns out to be mental health, they can reach out on the radio and get the best team clinician to respond to their scene as well. It provides availability of a jail diversion certified peer specialist, because peers aren't just important for officers. Working with someone who has a life experience and understands the systems can be enormously helpful. The potential for cost saving to the city can't be measured. There is a decrease in arrest, emergency department visits, 911 calls for service can be reduced if you've effectively handled a situation in a home. And it saves officers time. They can respond to other calls for service by minimizing these calls coming in through 911. Officers communicate with clinicians about their own issues, and it gives them a better understanding on how to respond to these folks when they're going into their homes and dealing with the mental health issues that they're experiencing. A lot of officers don't have the skills to talk to people. When you go through some of the trainings we're providing and you ride with best team clinicians, you get a better insight in how to respond to these situations. These are valuable resources, and I'm going to do everything in my power to increase the amount of best team clinicians we have on the street. Getting all of the officers sent through the crisis intervention training, I think that's a valuable tool. I went myself. There's a lot of things that we're doing, a lot of programs that are in place, and we're going to work to expand them and modify them when necessary.
Thank you, Deputy. Thank you. Jenna, you have more. Sorry, go ahead.
Okay. Just a few other things. We also
Sure.
have the hub table, which we've now been piloting in 2 of our districts in East Boston and Jamaica Plain. It's a Canadian model that we're also really modeling after Chelsea as well. But it's a really great, exciting pilot where you have a table with all of these experts. And basically, situations are presented to the table where people are at elevated high risk for at least 3 different factors, but suicide is one of them. And then they'll get immediate intervention, hopefully pre-crisis. And so it's a really valuable program that we've already, I don't know the exact numbers, but it's going very well in East Boston and Jamaica Plain, and we're hoping if that pilot continues that we'll expand that to other districts as well. And BEST is also heavily involved in that. We also do assist the homeless through our street outreach team. Officer Al Zalaway is incredible and do a lot of proactive outreach, which would also help towards that vulnerable population. And moving forward, we have a lot of future next steps that we expect to take. As I mentioned earlier, Chief Long is looking to expand and improve our peer support unit, which is already a national model, but there's a San Diego model that we're really hoping to kind of model. I say the word model a lot. Our program after, we'll need some resources for that, but we're hoping to provide more comprehensive services to people who need them. Expansion of our co-response model, as Deputy Stratton mentioned, with more clinicians on more shifts. And we'll move to schools soon, but one of the major advantages of that is if we have clinicians working that daytime shift, then they'll be available to co-respond in schools, because I know part of the issues is a slow response to schools, and so having a co-responder during school hours would be enormously helpful. We're going to be doing a dedicated car pilot. Right now, our co-responding clinicians ride along in a car that is not designated specifically for mental health. So if that car gets called to a burglary or a robbery, the clinician has to just wait in the car, and it's not the ideal use of the clinician's time. So we're going to be doing a pilot program, and we're working with Dr. Melissa Morabito out of UMass Lowell to evaluate that, hopefully make the case for the funding being worth it to take out an officer in a car for minimum staffing levels and have a dedicated mental health car. We're going to continue getting as many officers CIT trained as possible. Thank you to DMH for funding that. We're learning about best practices in other cities. Lauren Snyder from Best and I are going to be going down to Houston in March to see what they do because they have a great model. They're a CSG learning site. And finally, if you want to end with your proposal.
Yes, I'm also in talks with Commissioner Gross and his Chief of Staff, Deputy Superintendent Dennis White. I want to create a unit of officers whose sole focus is to provide outreach. They won't be tied to the radio system. Their role will be to go into the communities and talk with people, try to convince people to seek the services and the help they need. We have several officers that are doing that now on their own, but they don't have the time because the next call is coming and you got to clear and you got to go back into service. I'd like to have this team of officers to be able to go out on the street every day, and all they would have to do is encounter people on the street, talk with them, try to convince them to get into the services they need, whether it be due to substance abuse or mental health. And the value of this unit is they're not tied to the radio, so they can spend as much time as they need with these individuals. And if we do get some folks into treatment, we get to stay with them, monitor the treatment, be ready when they're coming out to provide further treatment if needed, temporary housing. Like I said, some officers are doing this on their own already. I want to pull together a team and have the focus and the resources to be able to address these problems that we're encountering every day. And this would definitely result in fewer calls for service because we'd be getting people into services and they wouldn't be coming right out and put right back on the street. If we're there to meet them, we can continue services. And like I said, the temporary housing is huge, maybe job training. But this is a proposal that I've created, and we're in discussions to create this unit. I think it'll be a valuable tool.
Great. Thank you for sharing that, Deputy. And thank you, Jenna. I think we're ready for Dr. Love. Good morning. It'll come on. There we go.
There we go. Thank you for hosting this convening, Councilor Asabi George, and thank you, Councilor Flynn and Councilor Campbell for attending. My name is Jennifer Joselo. I'm the Medical Director at the Boston Public Health Commission. I am also a practicing family medicine physician and primary care provider at Greater Rosendale Medical and Dental Center, which serves West Roxbury, Rosendale, Hyde Park, and the surrounding communities. So mental health issues and suicide are something I deal with on a regular basis as a provider, and I feel very passionate about connecting clients, not just as my role as in the commission, but also as a primary care provider. So the commission has long been aware of the public health crisis. As mentioned in the Docket, suicide is the 10th leading cause of death in the United States, and the rates in Massachusetts have increased by 30% over the last 15 years. BPHC relies heavily on data to look at health trends in the city of Boston. So we have seen through our data analysis that persistent sadness has increased over the past years. Thank you. Over the past years in our youth, and we also see an increase in persistent anxiety. Thank you. And poor mental health in the adults in our city over the past few years. And this is actually higher in Boston in comparison to the rest of Massachusetts and the country as well. In looking at suicide specifically, we have not seen an increase in suicide rates in Boston. They've remained fairly stable, but we do have specific populations where there are disproportionately higher rates in suicide. So this slide indicates that for Black residents ages 15 to 24, they are twice as likely to succeed to complete suicide in comparison to their white counterparts. Again, this is in contrast to what we see in the rest of the state as well as the rest of the country. I think we've already alluded to very high-risk populations, the veterans as well as first responders. In our youth risk behavioral surveillance system, 2017 data also indicates that LGBTQ youth are more likely to have persistent sadness as well as have suicidal behaviors, which include thoughts of suicide, making a plan for suicide, and actually attempting suicide, so in comparison to their non-LGBTQ counterparts. So there are clearly specific populations that are at higher risk of completing suicide. So, sorry, I did this one. This one? Oops. There you go. All right, so over the years, BPHC has implemented many changes to our system to address suicide as a public health crisis. In 2015, as I mentioned, we have a strong, we look at data very closely and have a lot of data accessible to us. So EMS, Emergency Medical Services, has access to our safety pad data, and they were able to start a system where they would scrub the data more consistently to specifically look at calls related to suicide. In that same year, our research and evaluation team began to analyze our Health of Boston data to look at suicide rates by neighborhood. So based on the trends that we saw in these data points in 2016, we hired a consultant to do a deeper dive into the data to look at trends and to make recommendations of what we could do for future initiatives. In that same year, BPHC participated with other Health and Human Services departments, Health and Human Services cabinet departments, to launch initiatives on suicide awareness and suicide prevention. That largely was around suicide awareness trainings in partnership with Samaritans. And over the years, there are many programs that the Commission has initiated to address specifically mental health, and I'm just going to list a few. The BEST team has been mentioned quite a bit in the program already, but the EMS and the BEST team collaborate to provide 24/7 responses to adult and youth in need of crisis intervention. Our homeless services bureau, as well as our recovery services bureau, we have mental health clinicians on site, and we also can provide mental health services through many venues. We have the outreach workers, we have the clinicians on site, and we can connect them to crisis intervention. We can provide on-site counseling as well, and connect to resources out in the community if needed. Within our Child, Adolescent, and Family Health Bureau, we have the Early Childhood Mental Health Program. So that's addressing youth ages 0 to 8, as well as their families who may be at higher risk of having mental health issues. We also have the Neighborhood Trauma Team, and they work to provide clinical services to those members in the community who are repeatedly exposed to violence or who are exposed to a violent event. So both of those programs combine the clinical aspect with community outreach so that we can reach residents who might be at higher risk for mental health needs or crisis intervention. And finally, I'm also just going to mention our school-based health centers. Boston Public Schools will probably discuss this, but we have a number of school-based health centers, again, with mental health clinicians sitting in the school to provide a variety of services, including specific mental health counseling, as well as referral to outside sources and crisis intervention if needed. So all of these initiatives have been created at the Commission to extend the health system available for mental health services and suicide prevention, but obviously there's a lot of opportunity that we have to improve and increase the system. So one of the main barriers to that is the stigma. We've already mentioned a lot about stigma, but this idea that you're embarrassed or you're fearful of admitting that you are sad or depressed or suicidal, or even one step further, stating that somehow persistent sadness and persistent anxiety is a normal part of life, and that to admit that you actually need help around it is somehow a weakness. And then beyond that, once you do identify that you have a mental health issue, actually accessing services, we are fortunate that we have plenty of mental health services in the city, but it's still very difficult to get into a clinician, and this is particularly true for our vulnerable population, the homeless, those suffering substance use disorder, if you can't speak English, or if you don't have health insurance. So those are just specific populations, but mental health services are somewhat limited in the city as well. So that being said, our goal at the commission is to ensure that all residents of Boston have access to mental health services, regardless of where they are on the mental wellness continuum. So if they're just dealing with daily traumas or daily stressors, to normalize the idea that you can seek services at that point in your life. Or if you have repeated trauma from violence in the community, or if you have severe mental health, or if you're in crisis, it is all acceptable and appropriate to reach out for help at any point in that continuum. So to that end, in the future, the commission has a set of goals to complete in the future. We want to emphasize that our strengths really lie around providing data for the community and resources for collaboration. So as I mentioned, in the future, we are going to reach out to our partners who have access to data. We have access to real-time data to see what the continuing trends are in suicide rates in the city, and to reach out to those populations who don't reach out for themselves, to find those populations and those individuals who haven't connected with resources, and to encourage them to connect to resources. We also plan to continue our partnership with Samaritans. I know they're going to speak later on providing training to our staff as well as community members to increase suicide awareness in the community. And finally, we hope to host convenings with our community partners to identify what gaps might exist for access to care. We actually initiated this process over the summer. We hosted about more than 400 young people in the city to hear what their thoughts were on mental health in relationship to violence. So we have plans to gather that data, review it, and launch some initiatives around the information we gathered. So thank you again for inviting me to talk today, and I hope that we can collaborate with the future.
Thank you, Dr. Lowe. And I will, before we get to Andrea, I just want to recognize that we've been joined, as many of you have noted, Council President Andrea Campbell. Thank you, Councilor Campbell. Andrea, sorry. Andrea.
Thank you, Councilor Flynn. We're really excited to be here today to talk about the behavioral health services that are happening in Boston Public Schools. So we'll talk about overall the needs of our students, what our Department of Behavioral Health Services does, and let you know about some of the initiatives and partners that we're working with to address the behavioral health needs of students. But just an overview of behavioral health needs of our students. We know that students in urban districts are 20% more likely to experience adverse childhood conditions. And a recent study from the Boston Public Health Commission and Children's Hospital indicated that 1 in 5 of our own children in Boston have experienced 2 or more adverse childhood experiences. Students are often first identified as needing behavioral health in schools, and so schools are a critical part of that entry into systems of mental health care. We also know that the school community partnerships that we'll be talking about here today are critical in creating that systems of care for students and family, and that mental health services, when provided in schools, reduce stigma. And you've heard people talk about the need to address stigma in providing mental health services. The Boston Public Schools Behavioral Health Services Department is really committed to providing a continuum of behavioral health supports that starts with preventing behavioral health issues and promoting positive and strong behavioral health skills in our students. Additionally, we work to do at-risk services and intensive services. A portion of our work is convening and collaborating with a wide variety of community stakeholders to ensure that their supports are being brought into the Boston Public Schools. A quick overview of the Department of Behavioral Health Services, and we thank you all for your support. We currently have 2 administrators, myself and Yvonne Barrero, 1.5 clerk positions, 71 school psychologists, and 8 pupil adjustment counselors who are social workers. So this staff of 80 mental health services sit in the Department of Behavioral Health Services in BPS. We also have social workers that are in school-based positions that don't sit in my department. And together we work to provide a continuum of behavioral health supports to schools, from such things as teaching social skills and helping schools create safe and supportive climates at a prevention and promotion level, to working on important initiatives like the Comprehensive Behavioral Health Model and Sandy Hook Promise and community mental health partnerships, to doing Tier 2 services, targeted social, emotional, and behavioral health programs for kids at risk, and intensive services like crisis response, individual counseling, functional behavior assessments, and behavioral intervention plans. This group of 80 central office staff during the 2017-18 school year responded to 2,787 crisis events. They conducted 312 suicide risk assessments, 253 threat assessments, and responded to 66 large-scale district crisis events. So the school's very committed, my behavioral health services staff is very committed to supporting the behavioral health needs of students across the district. One of our large initiatives that many of you are familiar with is the Comprehensive Behavioral Health Model. It's currently in 70 schools, supporting over 31,000 students. And the model is based on the premise that if we support students' behavioral health early, we can mitigate the impact that behavioral health issues have on academic outcomes. We can also support school staff to increase their capacity to address behavioral health in schools. A couple of key features of the behavioral health model is a universal screening, and I'll show you some data on that. We're one of the few nations in, schools in the nation that use a universal behavioral health screening tool to find students with behavioral health risk and intervene early. Another essential component of the model is building strong partners, and many of our partners are here today, and you'll hear from some of them. We also work to provide direct social skills instruction in these 70 BPS schools. Our universal screening tool is the BMAS-2, Behavior Intervention Monitoring Assessment System, and it looks at both issues that we want to reduce, concerns in conduct, negative affect, and cognitive attention. It also looks at positive behavioral health that we want to encourage and increase, those adaptive behavioral skills of social and academic functioning. This screening tool allows us to find the very kids that we're concerned and talking about here today, those students with internalizing risk that are at risk for social isolation, depression, suicide. And the exciting news is by doing the comprehensive behavioral health model, we're able to have incredible effect and impact on students' performance. So because I didn't have a lot of time to show you all of our data, I just wanted to share one slide that shows that the impact of CBHM is greatest among students with high needs and negative affect. Again, these are the kids that are experiencing some level of anxiety and depression. And so we're excited to say that we know when you do behavioral health well in public schools, kids can get better. And so students are having a 0.8 effect size in cognitive attention, a 1.0 effect size in conduct, and particularly what we're talking about here today, negative affect, a 1.2 effect size. That effect size is showing the effect that our interventions in CBHM are having on students. Academic functioning and social skills. So again, we're really excited to show that when you do intentional work with behavioral health, students are getting better. But we're not doing this work alone. We're doing it in conjunction with, obviously, with school staff. Our biggest lever, we're working closely with principals and teachers to develop a continuum of interventions. We also work very closely with a large number of partners, including universities, and I know some of them are in the room today. UMass Boston, William James, Tufts, and Northeastern are our local universities that we work to train university students to become the next generation of mental health providers in schools and school psychologists. We also work closely with hospitals. Children's Hospital is one of our founding partners, and we're able to bring the resources of hospitals into the schools. We also have very deep partnerships with a wide variety of community partners, like the Boston Public Health Commission, the BEST team, DMH, Boston Police help us with a great deal of our mental health responses. And whoops. One of our latest important partnerships is with Sandy Hook Promise. The mayor has really committed to bringing Sandy Hook Promise to the Boston Public Schools. They're helping us do an array of supports, including suicide prevention, threat assessment. We're also teaching kids to say something. If they see something, say something, and make relationships with their kids and peers by the Start With Hello program. And this year, we're piloting an anonymous reporting app so students can report any threats of suicide, homicide, bullying that they see in their community. And these are the different aspects of the Sandy Hook Promise program. Say Something, anonymous reporting app, and the threat assessment. And as I mentioned, a wide variety of our community partners are helping us cross the continuum from prevention and promotion with things like signs of suicide, break free from depression, to interventions that are for groups of students or intensive interventions for targeted students. And we have also given additional information about the work we're doing. We would just like to thank the mayor and the council for giving us 10 behavioral health positions in this year's funding. That's made a big difference in the amount of support we have available to schools and students and staff. So thank you for that.
Great. Thank you, Andrea. And then last on this panel, but not least, Kelly, introduce yourself, please. Thank you for being here.
Good morning. My name is Kelly Cunningham, and I am the Director of the Suicide Prevention Unit at the Massachusetts Department of Public Health. I want to take a moment and thank you for inviting us to speak about this very important topic. For my part, I would like to talk to you about what is happening at the state level. With more than 45,000 people dying by suicide each year in this country, suicide has become the 10th leading cause of death and the second leading cause of death for ages 15 to 34. Although Massachusetts has one of the third lowest suicide rates in the country, it has seen a 30% increase in the last 15 years. Most recent data shows that in 2016, there were 638 suicides. One reason why Massachusetts rates are lower than other states is we have one of the strongest gun safety laws in the country. The Massachusetts 2014 Act to Reduce Gun Violence requires Department of Public Health to submit an annual legislative report detailing suicide deaths and collecting data on firearms. Suicide prevention is typically broken down into 3 parts: prevention, intervention, and postvention. The Suicide Prevention Unit at DPH funds over 20 providers throughout the Commonwealth who provide services in all these areas, paying particularly close attention to those who are at higher risk of suicide, including older adults, LGBTQ community, veterans, youth, and middle-aged men. Prevention, which is defined as services provided to prevent a suicide from occurring, generally begins with training and awareness. The Suicide Prevention Unit provides a number of trainings throughout the year to anyone who is interested in gaining more skills or knowledge on the topic of suicide. We also offer an annual 2-day suicide prevention conference every spring as a resource for the community, which is attended by over 500 participants each day. The conference is attended by providers, clinicians, school personnel, loss survivors, and attempt survivors to hear about what is currently happening in suicide prevention. Intervention supports an individual when they are actively in crisis. State funding supports this work through our helpline and treatment services. The statewide helpline number, 1-877-870-HOPE, is answered by 4 individual Samaritan branches and answers more than 100,000 calls per year. Massachusetts is also fortunate to be part of the National Suicide Prevention Lifeline, funded by SAMHSA, which is Substance Abuse and Mental Health Service Administration, and includes approximately 160 crisis centers from across the country. The service is similar to our statewide hotline number. However, it is a nationally recognized number that some may prefer to use. When you call 1-800-273-TALK, you are directed to a helpline in your state. Additional intervention work being done across the Commonwealth is a newest strategy called Zero Suicide. The Zero Suicide goal is to reduce the number of suicides through quality improvement within healthcare and behavioral healthcare systems. This work includes evidence-based strategies such as universal screening, treatment, safety planning, and follow-up. There are more than a dozen systems in the Commonwealth committed to this endeavor, some as close as Boston, as far west as the Berkshires, and currently beginning work on the Cape and the Islands. And also, DMH has implemented Zero Suicide throughout their agency. I assure you, this is not work that can be completed overnight. It requires leadership and system change to make this work. A commitment to Zero Suicide is a commitment to treating suicidality as you would any illness and treating the patient beyond the walls of the hospital. Intervention strategy also includes work with attempt survivors. When I started in this field 11 years ago, we were really hearing from lost survivors. Over the last several years, we have learned more from those who have been suicidal or have attempted suicide than we ever expected. Support groups for attempt survivors and family members of attempt survivors have been formed throughout the Commonwealth, and folks with lived experiences are now required members of many committees. Unfortunately, we all know too well that suicides do occur. When this happens, postvention work is critical. Postvention describes services that occur after a suicide. There are a number of support groups for those who have lost a loved one to suicide throughout the state. They provide an opportunity for the lost survivor to be with others who have lost a friend or family member to suicide. This can be a very healing experience as people share their stories and experiences. I believe you'll hear more about this from 2 of our other providers on this panel. Postvention work is provided through state funding to communities and schools when a young person dies by suicide. In these instances, our postvention provider, Riverside Trauma Center, will go to a school or community to help through the loss. Services can include immediate steps to take after a suicide, guiding schools to understand how this affects others, and providing additional clinical support to the school. It should be mentioned that our work could not be done without the support of our sister agencies. A few include the Department of Mental Health, Veterans Services, Department of Elementary and Secondary Education, and Elder Affairs. Our work continues to expand as we learn more about the issues related to suicide. Examples include problem gambling and the opioid crisis. Both represent areas which are high risk factors for suicide. We are currently working on projects which will help foster awareness and support to the intersectionality of both topics and suicide. The continued work we do would not be possible without the backing of the Massachusetts Coalition for Suicide Prevention. MCSP is responsible for advocating for funding for suicide prevention in the state, and they are responsible for the state strategic plan for suicide prevention, which is currently in review. They have 10 regional coalitions located across the Commonwealth who also bring additional training to the communities. In closing, you can see there is a lot of work being done. We are hopeful that the expanded work around intervention services and discussions like this today can make a difference, in part by keeping a public focus on reducing the number of suicides we see each year. On behalf of the Massachusetts Department of Public Health, I thank you once again for the opportunity to speak today.
Thank you, Kelly, and thank you all. Really very informative presentation from all of you, and I've learned a lot, and I would caution my colleagues that we could go down some rabbit holes today and really talk in length about this topic. So just as a reminder to everybody that we do have two more panels following. So I'm going to offer my colleague, Councilor Flynn, an opportunity to ask any questions of this panel.
Thank you, Councilor Asabi George, and to the panelists for your informative discussion. I learned a lot by listening to you. I did take some notes, and maybe I could try to ask a couple questions if I may. Dr. Lowe, as part of Boston Public Health Commission, I noticed the rate of suicides by Asians seemed high. Was there a reason for that?
The mics will just come on.
Okay, sorry. So the rates of suicide by Asians, from what I recall, we need a specific number of suicide deaths for the data to be significant. So I'll have to check in with the Research and Evaluation Office, but I believe in comparison it's actually lower.
Okay. It seemed like it was kind of in the middle in that chart.
Okay.
I represent Chinatown,
Yeah.
so that would be a concern for me. I do plan to work with Public Health and have a conference sometime in January in Chinatown on public health concerns for the Asian community, but maybe we can talk about that before.
I can touch base with my Research and Evaluation Office and get you some data points before that convening.
Okay. Also, Deputy Stratton, I had an opportunity to be at several meetings with you over the last several months, and just want to thank you for your outreach to so many people, especially on Mass Ave, Albany Street, Southampton Street. I think you and the police are doing a very good job with limited resources. I would certainly, as I mentioned before, support you and your program to have a dedicated group of police officers that can kind of track mental health in the homeless community. So I think it would be a great program. What specifically can the city council do to be helpful to you on that program? I know you're also looking at Section 35 in working with the court system in identifying people that may need immediate access to mental health counseling, even if they don't want to get it. But is there a role of the city council can play in terms of making some outreach to the court system?
Well, they're already doing some of it. It's a funding issue. A lot of the things that we're undertaking require manpower and resources and time. So after speaking with the commissioner and Superintendent White, we discussed my initiative, and there's an academy class that's starting today, coincidentally, and when that class comes out, it provides more manpower. So once we have the staffing levels increased, I'm able to draw from the district specific manpower to address these issues. The districts and the offices are doing phenomenal work in addressing it. The training that we're receiving is very helpful. You have to have a better understanding of what you're dealing with in order to provide services, and we're getting that training. But I want to be able to be more committed. The officers do a great job at responding to calls and handling the call for service. I want to do more in the field of, well, what do we do after that? Because we're seeing the same people over and over come back to the streets, whether it's a mental health issue or a substance use disorder issue. They're going for treatment, and then they're coming right back to the street. So I want to get more involved in the hearings at the court with respect to Section 35, the involuntary commitments. I want to be able to have men go to and women go to the hearings and follow through. What's the disposition? Where are they going? What kind of treatment are they receiving? And when those preliminary treatments are done, detox or rehabilitation, they're introduced back to the street, and in most cases with no resources. So I want to be more involved in that process so we can visit with them while they're in treatment, let them know we're still in their corner fighting with them, and have an idea when they're going to be coming out to the street so the officers can work on securing long-term housing, further rehabilitative services, and maybe job training. But we definitely need a group that has the time. It's all about time and commitment. The officers have the commitment, they don't have the time. You have the calls for service that tie us up for most of the day. So if I had this team of dedicated officers, and several have reached out to me, already want to be a part of this unit, I think we'll be very effective because we're going to be in it for the long term, not just going to people's homes or on the streets and providing an initial response, and then we're out of their lives. I want to stay involved and ultimately be able to work with the families as well, because when you become involved with some of these folks on the street and you talk to them at length, the families have become disenfranchised because of the difficulties of the substance use disorder. I want to be able to reach out to families, let them know we're working with their children, and I think that will help them get back involved in their children's lives and offer that support, because I think that's going to be a big factor in their continuing their rehabilitation and ultimately maintaining their sobriety.
Thank you, Deputy, and for Jenna. I know Boston Police, Boston Fire, EMS, they experience trauma almost every day or every shift or every other day or so. What type of medical care or what type of services are provided to Boston Fire, Boston Police, especially EMS, EMT? They experience so much trauma almost every single day that at some point it has to take a toll on them. What could we do to help our dedicated city employees?
Well, like Jetta said earlier, Commissioner Gross, one of his #1 priorities is officer wellness, and the peer support unit that we have is critical. It's been expanded. One of the supervisors over there, Sergeant Detective Mark Freary, does a phenomenal job at coming out to the districts, talking with the officers, talking with the leadership, and he stays involved. And I think that makes it more comfortable with officers being able to go to him to seek any help that they need. But that peer support unit is there. It's being increased, and we just have to do a better job at getting rid of the stigma, so officers will feel more comfortable in going and seeking out these resources.
And for Andrea, what can we do better in the city instead of having mental health counselors working at a school, 2 days a week, 2.5 days a week, and then going to another school for 2 days a week? I don't like that system. I want a dedicated mental health counselor in every school 5 days a week. When you're at a school for 2 days a week and then you have to go to another school for 3 days a week, what happens to that other school that is left unoccupied? And having said that, I'm also concerned about language access. Our mental health counselors, are they communicating in the student's language? And is that mental counselor always available for that student? Do they speak Cantonese? Do they speak Mandarin? Do they speak Spanish? Do they speak other languages? It has to be a better system than that.
Let me start by saying I sincerely appreciate your support and the council's support for behavioral health in Boston Public Schools. It's through the support of yourselves and Interim Superintendent Laura Perrell and Deputy Superintendent Charles Granson that we now do have 71 school psychs. So you say mental health counselor. In Boston Public Schools, we specifically have school psychologists who are licensed mental health providers who can provide that continuum of support. When I first started as an administrator in our district, we had 48 school psychologists. So currently having 71 feels like we've made a lot of progress, but there's a lot more progress to go. We agree with your vision of having behavioral health supports in every school every day, and we've gotten there through blending lots of funds, from principals being able to buy additional time, from the central office creating new positions, from the commitment from the mayor's office. We also work with community mental health providers, and many of them are in the room today, like Home for Little Wanderers, that brings in mental health clinicians to add to the supports that we have internally. So it is a multi-pronged approach of increasing behavioral health services to students. In terms of your linguistic question, our staff is very diverse in behavioral health services. We've made a very concerted effort since 2007 to hire racially and linguistically diverse staff. We do that through partnering very intentionally with our university partners, who again are in the room, to take bilingual candidates at the university, bring them to BPS as interns, and then hopefully hire them. So we have school psychologists that speak Spanish, Russian, Haitian Creole, Portuguese, Chinese Cantonese, Chinese, Mandarin, Arabic, French, sign language. And we continue to, with every new hire, look for, again, racially and linguistically diverse candidates so that they can meet those linguistic needs of our students.
Is there a list of, a running list of kind of holes in the system where if a student is looking for a mental health counselor and that counselor is not there, do we document that?
So
Or do we document that like 6 hours later, the counselor was able to speak to them?
So let me just start maybe with a little bit of context that currently mental health funding for our partners comes through Health and Human Services and Department of Mental Health to the funders, not directly to schools. So there's kind of two systems trying to work together to do behavioral health. There's school staff, and then there's community partners that are paid through medical insurance. And what we've done in BPS is try to be very intentional about braiding those two systems to get access to care for students. So one thing we have, as an example, is our school-based mental health collaborative, and each month I lead a collaborative with Boston Metro DMH and Charlene Savante, and we bring those partners in to meet with BPS staff so that we're trying to braid those two systems of care. And actually, today at this time is our monthly meeting, so some of our partners came today, and I think they'll be speaking during the open testimony section to tell you about the work that we're doing. And so when a student needs help, and it comes to school, sometimes families choose to seek help through their primary care doctor, and they get help that way, or through their community health center. But when the issue is known to the school, we have student support teams at each building. That team is comprised of nurses, behavioral health services staff, the principal, teachers, and they sit and discuss the needs of a student, and they determine which interventions might be the best fit, and then do referrals. And sometimes schools have partners in their building, and they can refer the student directly to the partner that's in their building. If not, then they're referring the families to partners within the community. So in 125 schools, that system, student support system, looks a little different depending on if it's a huge school that has a broad student support team and many mental health partners, or a small school. But the behavioral health services team is there to help make the connection to services for folks, for students and staff. So we do track which students are referred to for support and which students and which support they're referred to.
I think going forward, in my case as a city council, I'm gonna have to spend more effort making sure that we try to have as many counselors in each school, in each one. You know, we partner up with the various language is also a concern. But I didn't, my first year, I didn't focus on that all that much, but I should have done a better job researching that. But having a handful of counselors and moving them from school to school is not a good system. It's a system for failure, and we need more counselors in there. This city's booming. You know, there's so much money in the system, in this school, that, you know, to have a handful of counselors and not one counselor in each school is not a good system. So that's something going forward, I think we're gonna have to focus on. Now, I just have one more final
Great.
question.
Quick, brief, thank you.
Then, that's okay.
Then we'll do another round.
No, that's okay.
You sure?
Yeah, I'm fine.
Okay, thank you, Counselor Flynn. Counselor Campbell.
Thank you, Councilor Sabi George, and thank you for hosting this and for your work through the committee on this work, on this important issue. Thank you to all of the panelists as well for being here and the panelists to come. I may not be able to stay for the whole hearing, but we'll absolutely review the tape. And I know there's a lot that we're taking in. I think Councilor Sabi George designs the hearing so that we can sort of have interaction with as many folks doing the work as possible and be able to follow up. I really was focused on the data piece. I represent District 4, which is largely Dorchester, Mattapan. Those are my biggest neighborhoods, a little bit of Jamaica Plain and Rosendale. And so the data that you put forth reflects what we sort of talk about on the ground in the community. The largest impact affecting Black men and Black young men. And that data point is probably true for so many different categories, right? So we know that race plays a role in this. We know that systemic racism and other things play a role in these numbers. So I appreciate deeply the work that you guys are doing to address it. I just had, I guess, a couple of follow-up questions. One was specifically around reach. You know, how do you reach those individuals that are tough to reach? And what I mean by that is I hosted a public safety meeting recently in the district. There was a shooting right outside the meeting, literally as we were having the meeting. And we sort of were talking about mental health at the time that incident was happening outside, and talking about the importance of not just reaching residents or quote unquote victims, but even those that may be gang involved, those we might call impact players, perpetrators, who also have serious mental health concerns and are thus participating in certain types of behaviors as a result. So I'm curious how we go after and reaching those individuals, and anyone can sort of speak to this question.
Campbell, a very important question that you raise, and you know, reaching the underserved and the particularly vulnerable population is an especially difficult challenge for all communities. Many of these people who are dealing with mental illness, substance use disorder, who interface with the criminal justice system, that is probably, if not too late, but at least one portal of entry for services. I'd like to mention our Veteran Justice Outreach Program in the VA, which works with a number of different veteran justice courts to provide treatment and diversion to involvement in the criminal justice system, incarceration, et cetera. So for that population at risk who are engaged in criminal behavior, I think that's an important piece that we need to keep on the table, working with Boston Police and local courts to identify those mental health needs and provide treatment either as diversion to sentencing or true mental health treatment within the context of our jails and prisons. 30% of the mental health care that goes on in the United States happens in the context of prisons and jails. So this population is vulnerable to engaging in unlawful behavior and often gets treated within that context. I'd like to see a system where these people are diverted from incarceration, who are treated in their communities, get reconnected with the support systems in their communities to rebuild productive lives.
Hi, I'd like just to mention our Division of Violence Prevention. So the idea behind the neighborhood trauma teams as well as our Village in Progress programs is to connect clinicians and community organizations that are familiar with community members. So speaking to your point about those out in the community who might be perpetrators, who are just in the community and need services, by utilizing community organizations, they become they are aware of these individuals who might need help and are repeatedly available, so that they can build that trust in order to connect these clients back into services. So it's about actually going out on a regular basis. I think the Village in Progress program really speaks to that. They form partnerships within the community, not just because they are suffering a specific trauma, but they're building the resiliency, hopefully to prevent the trauma in the future.
It'll go on.
It'll totally turn on. A few things that just came to mind when you asked that question. One is the hub table, which I think is really key for getting at those truly complex cases where someone is may be criminally involved, but also at suicide risk and on the verge of homelessness. I think that is going to be a huge resource for getting at those truly vulnerable people. The Boston Police and BEST and a lot of other partners in the room have also been highly involved in the Community Justice Workshop, which is a statewide effort through the trial court, where they do sequential intercept mappings. I know Councilor Sabi George has attended these. I think you actually come as well. I think these are also really important because they look at all, the entire criminal justice spectrum and all the different ways that people with mental health and substance abuse issues can be intercepted from criminal justice system. And so even if you're pretty far in, you've already served time for a violent offense, whatever, like, it's never too late to try and intervene and try to get you the resources that you need and the help from the community, from Intercept 0 all the way to reentry and Intercept 5. Oops, sorry. And finally, I'll defer over to Deputy Stratton, but I also thought immediately of if we were able to do this proactive unit, focusing on those high utilizers. I think that's really key in working with Boston EMS and with BEST. It's the same people are being seen over and over again for crime, for homelessness, for suicide risk, for overdoses. These are the really high utilizers of the system, and I think having a proactive unit that can address that and provide follow-up, I think, will be really key.
Yeah, I think it's continued outreach and communication. Communication is the key. We got to work with all of our partners. It's not just the police. Come in with Department of Mental Health, outreach workers, counselors, the BEST team, clinicians, the Mayor's Office of Recovery Services. I think if we get involved and we bring all the people to the table that can offer the different resources that they're going to need, we're going to be more effective. But it's the communication, bringing the church back into the equation, constant outreach, and break down the barriers. We got to do a better job at meeting people in their homes and on the street and just engaging in communication and letting them know we're there to help. Diversion where necessary. The intercept model, we're going to be engaging folks at many different levels. Hopefully we can get them sooner through education in the schools, but we're not going to give up at many different levels. And it goes back to the Section 35 and the Section 12 hearings. We going to the court and be a part of that disposition from the court. Where are they going? What kind of treatment are they receiving? And how can we help? And what are we going to do when they come back out? So I think if we continue the outreach and the team concept with all of our partners, we'll be effective.
This is extremely helpful, and I do want to go on the record as we go into the new fiscal year, next year, and budget hearings, fully support the unit you're talking about, more BEST clinicians. I think we do have the resources to do this work. I will tell you, I think, we put a lot on our public safety agencies in responding, particularly police, and this expectation that you guys can solve all this by yourselves. And in addition to that, I do think a lot about the officers that have to, day in and day out, deal with incidents of violence or even things that may be small, but someone spitting in your face or someone throwing something at you, and there's no sort of requirement that you go back to counseling after something like that. So I want to definitely continue the conversations around wellness. I will add, and just to be mindful of time, the piece about stigma, the additional layer that you were talking about, that folks in the community feeling as though feeling sad or depressed is a normal way of being, right? A normal way of being in this sort of life. That is huge amongst young people. I mean, one of the things, we did a lot of listening in this meeting. That's what came up from the he was 19-year-old young kid to the 71-year-old man who was in our meeting, and talking about fear and feeling fear and being afraid, and thinking that's sort of a common way of living, which of course it isn't. So I look forward to being a partner in the work, and circling back with many of you on how we push the city to put the resources to these types of initiatives, and to come together around this. But thank you so much for the work you do, and to the folks in the audience as well. Thank you, Councilor Asami-George.
Thank you, Councilor Campbell. I do think that what Dr. Bradley started with certainly is meaningful to service members, but I just want to read from your presentation, because I think we can replace service member with any other constituency in the city of Boston, certainly. But when service members transition successfully into their communities, become well integrated into support systems, and achieve financial and occupational stability within those communities, their risk of maladjustment, substance use disorders, and ultimately suicide is diminished. And we can take any one of the other demographics that we've talked about today, so I appreciate you sharing that. Also, Dr. Bradley, in your presentation, you mentioned the regional referral system for acute and subacute psychiatric inpatient care with the 124 beds. Can you talk a little bit about where those beds are situated?
Certainly. Those beds are situated at VA Boston's Brockton campus, so just outside of the city. And 55 of those are for acute psychiatric stabilization, and then we have a 55-bed step-down unit and 14 beds that are dedicated specifically for substance use detoxification.
Then can you talk just briefly about because I know Deputy Stratton talked a little bit about the impact on some of our officers and on our firefighters, but there's often a common relationship to the veteran services. Can you talk a little bit about the overlap that might exist?
Well, certainly. As Deputy has mentioned, many of the police and fire and first responders within the city and around the Commonwealth are veterans themselves. I've heard estimates up to 80% in some departments. So there's a huge overlap both in their occupational exposures to combat, military service, and violence on the street, and also an overlap in terms of their eligibility for all sorts of support services, both within the VA and many who might choose to use their private health insurance for care. So there's a tremendous opportunity for partnership within police and fire and first responders with the VA in managing these veteran service member public servants and providing resources to them and assistance with adjustment in the wake of trauma.
Is that model at all followed in other sectors? When we think about our young people, we think about the LGBTQ community, we think about other specific demographics that are disproportionately impacted. Has your model been copied in other sectors?
I'm not certain to the degree it's been copied for LGBT groups or other demographics. I know there is a pilot project that we're embarking on here in the Commonwealth between VA Boston and the Bedford VA and many of the universities in the Commonwealth to provide veteran adjustment services to educational benefits and counseling for integration back into the education system after a period of service. So that's another, I think, promising collaborative that is going on.
Great. Thank you for that. And thank you for your work and for being here today. On the best clinicians, Councilor Presley and I worked really hard a couple of years ago, I think two budgets ago, on getting 4 clinicians funded through our operational budget, plus the 2 grant-funded positions, which would equal 6. I know we're talking about 5 because of some of the nuances with funding. How many would you like, Deputy Stratton?
There's 11 districts, I think, 22.
22.
A day shift in the first half
I
shift.
think it's important to know those numbers. I know it's certainly aiming for something, but we need goals to set when we're looking for resources.
We'd love to have one in every station, and if they couldn't be with every officer on every shift, at least they would be a resource for the other officers to communicate with through the shifts and just get some advice on how to handle certain situations. Like even if the clinician wasn't on a specific call, they could come back to the station, talk with the clinician, get some advice on how it could have been handled a little differently, a little better. Or again, call them over the radio if they're available. We're getting more and more calls for mental health related calls for service.
Right.
So I think the more clinicians we have, the better we can address those radio calls.
Jenna wants to add.
I so do. I mean, if we were going to ask for a magic number, I would say it'd be close to 30,
Yeah.
actually, because if you have 11 districts, 2 shifts each, that's 22, plus weekends, which we've never had coverage for. Plus, if we do get this new unit, I think that it would be really important to have clinicians also assigned specifically to that proactive unit. So I'd say up to 30 would be great.
And I also know that the training that our officers go through their training program through school, through
Academy.
the academy, thank you,
academy.
through the academy is really helpful, and that has changed over time.
For sure.
So as we increase and support that work, it's really important. And I know we also have a best clinician that is now a police officer, a former
We do.
best
Yes,
clinician.
Ben
that's now-
Linsky, yes.
Yeah, which is really fantastic when we think about the way that he and his new line of work can really support our residents across the city. So I look forward to that and think that it will be very, very helpful going forward. And then we had a presentation here maybe 2 months ago at City Council chambers, for city councilors on suicide prevention, and we'll hear from them later. But one of the concerns I have, and Kelly, this question's maybe for you because you gave us a couple of numbers, the 877-870-HOPE or the 800-273-TALK. It would be really wonderful if all of the organizations and the agencies that provide this work could settle on one phone number.
Totally agree with you, and that is something that we're desperately looking at. But you're talking about 5 different crisis centers that we have here in Massachusetts, and they all have different numbers. 4 of them are Samaritan's branches, so they follow the statewide number, and the 5th one does not. So I agree with you. I think that would be critical. I'm not sure if people are aware that the National Suicide Prevention Lifeline, there was currently enacted, there's a study going on, a survey about implementing a 3-number call, so that, like a 911, so that when you call that number, it would get you just to NSPL. And they also have, press 1 for veterans, so that's another way for veterans to be a part of that. In Massachusetts, Spanish-speaking callers who call the NSPL number, we're the 2nd highest number of callers in the country. So I think it's really critical for us to be able to have a 1 number like that as well.
Oh, wow, that's amazing. I didn't realize that number. Thank you for sharing that, and I wanted also an opportunity to share those phone numbers again. And then, Andrea, just, certainly support and echo Councilor Flynn's desire to have student support professionals in all of our school buildings full-time. With some of the apps that you presented to us through the Sandy Hook Promise and their work, who's monitoring the apps?
So once they get launched, we're piloting them this school year. We have a central office safety team that already exists for the crisis response. The way we're handling it is we already have a very robust district-level crisis team that works very closely with the Boston Police Department and Sergeant Detective Sexton. So it will be our same team at the central office and school-based office, school bases responding with a new source of information. So it will be my staff, the school psychologist, and social workers that work for me that are on the crisis team. Will we be working in conjunction with school-based social workers if that school has one, and if not, the behavioral health services team will own that response.
Great. I worry about bringing a new app online that I think is important to have, but we just need to make sure that we're able to pick up those communication, that we have someone that's responsible for that communication along the way. Because I think it could be it's a really wonderful tool that we need to have. We just need to be able to make sure that we can utilize it. Because if someone's sending messages and we're not able to respond, that can create a greater crisis that we would like to avoid.
So the anonymous reporting system gets monitored 24 hours a day by a national call center, and then the calls get pushed back down to BPS and BPD to work collaboratively to address them.
Great. Okay, that's the answer I wanted.
Okay.
I appreciate that. Thank you very much. Councilor Flynn, do you have another question for this panel before we let them go?
I don't have any questions. I just want to say thank you for being here, and more importantly, thank you for all your dedicated years of helping so many people across Boston. Thank you.
Thank you, Councilor Flynn. Thank you all. You're certainly welcome to stay. I appreciate your time this morning. We ran over, but I think we ran over with good reason. At this point, I'm going to, while you guys are exiting, I'm going to call up a few people for an opportunity of public testimony prior to the second panel. Is Brandy Fluker Oakley here? Brandy here? She signed in. Oh, okay, I don't see her in the room, but you're going to testify on behalf of Brandy. And then following Brandy, are you Jake? Oh, okay, very good. Yeah, I can call her later, sure.
Thank you so much, Councilor Sabi George and Councilor Flynn, Councilor Campbell, for having this important conversation this morning. We're really glad that this conversation is happening, and also that we're having an opportunity to speak to you about some of the work we've done. So my name is Jake Resiteritz. I'm an outreach director at Educators for Excellence Boston. We are a Boston-based nonprofit that's focused on giving a voice to teachers and educators. And this morning I'll be sharing some quotes from teachers who could not be here in person today. So thank you for providing me with the opportunity to share their thoughts with you. As part of our efforts to elevate teacher voice, E3 Boston has surveyed more than 1,000 Boston educators about their experiences over the course of the 2016 to 2017 school year. 91% of those educators stated that student trauma poses a major challenge in their classroom. In addition, in a survey this fall, over 500 educators overwhelmingly identified building strong relationships as a key factor to focus on when working to improve school culture. Last spring, Educators for Excellence teacher members came before you to advocate on behalf of their students and to urge BPS to hire more mental health experts. I've been really heartened to hear both of you this morning, highlight how important it is to have those staff in that school. So it's great. It sounds like we're building momentum. I want to remind you of their words and stories today, the ones that they shared this past spring. In May, Teresa Tolomer, a teacher at New Mission High School, shared with you the need she sees for increased support, saying that nearly every teacher has students in her class who have experienced trauma. And this is, I'm using her words, I am asking you to make sure that students all have access to professionals who can guide them through these difficult experiences, some of which include student deportation, violent or abusive relationships, homelessness or drug abuse, or even depression and illness. Students are struggling with these and other challenges every day, and what I've shared today is based exclusively on what my students have experienced over the last 3 school years. I'll also share the story of Matt Clark, a teacher at West Roxbury Academy, who shared a story about his student with a student named Catherine, whose emotional pain was keeping her from attending school. The student opened up to her teacher, Matt, about what was going on. And though he was able to call a meeting with himself, the student, and the school psychologist, they were able to ensure that Catherine would be safe in the immediate future and created a long-term plan for success. Immediately after this meeting, they observed a drastic improvement in Catherine's attendance and academic performance, but it took a collective intervention of a teacher, a guidance counselor, and the school psychologist, as well as Catherine's family, to make this happen. So strong relationships are essential, and without them, the problem might not have surfaced in this way. So I'll just wrap up by saying our students need access to mental health support staff, and schools must prioritize relationship building between students and staff beyond just academic support. Again, I'm really appreciative that you guys are highlighting this issue, and I hope to keep partnering with you. In addition to raising this essential conversation, the City Council should ensure that funding continues to be allocated to hire more psychologists and counselors for students to get to the recommended ratios, and that the district is prioritizing social emotional wellness for educators and students. We also need to continue to encourage schools to support educators and other school-based staff to build bonds of trust with their students and for adults to develop an awareness of student trauma. Thank you very much for taking the time today, and thanks for your continued efforts to support Boston's next generation.
Jake, thank you.
I have, these are the
Perfect.
written
You
ones.
leave them there. We'll come collect them.
Perfect, thank you.
Thank you, Jake. And then Leslie Feinberg from Home Base.
Thank you, Councilor Sabi George and Councilor Flynn, for your leadership in inviting Home Base to attend this important hearing on mental health and suicide prevention. My name is Leslie Feinberg. I'm the Director of Government Relations and Special Projects at Home Base, a Red Sox Foundation and Massachusetts General Hospital program. Massachusetts is home to approximately 380,000 of the more than 21 million individuals who formerly served in the U.S. Armed Forces. On average, 20 veterans die by suicide each day. This troubling statistic highlights the critical need for access to mental health care for our returning veterans. Homebase operates the first and largest private sector clinic in the nation devoted to healing the invisible wounds of war, such as post-traumatic stress, traumatic brain injury, anxiety, depression, co-occurring substance use disorder, military sexual trauma, family relationship challenges, and other issues associated with military service. Since inception, Homebase has served more than 19,000 veterans and family members with care and support, and trained more than 70,000 clinicians, educators, and community members throughout the country. Homebase is committed to eliminating barriers to mental health care. We are unique in that, 1, we treat the entire family, 2, we treat veterans and their families regardless of their ability to pay, and 3, discharge status does not affect access to care. In September of 2018, Homebase opened its new National Center of Excellence in the Charlestown Navy Yard. This new facility will allow us to double the number of patients we can see. Homebase is proud to call Boston home, a city that is unbelievably dedicated to their veteran community. It is an honor and privilege to work alongside a group of incredible veterans, clinicians, and administrators at Homebase that are dedicated to veterans and their families most in need. I thank you for providing me with the opportunity to share about Homebase today.
Thank you, Leslie. And then we do have Linda Freeman. It's going to be our last person for public testimony. While she's making her way down, I just want to prepare our panel too. If you'd like to quietly start making your way down to the front here, Dr. David Henderson, Dr. Carrie Landa, Astria Craig, and Sean Cahill.
Good morning.
Morning.
Thank you for giving me this opportunity to address the issue of the Asian community. I can probably answer that, and hopefully my Asian community will not be offended. Thank you, Councilor Sabi-Jordan, Councilor Flynn, and Councilor Campbell. Suicide in the Asian community, you have to remember there are different ethnic groups in Asia, and as they travel over here, they're culturally held to a higher standard of non-failure. Otherwise, it's a stigma in the community and in multi-generational, like among their multi-generation peers. You're talking about peers as in families of the grandparents, the great-grandparents, and they look at the whole thing. The other thing is, the example is like academics. The transition from home to university. You've never been away from so-called home. You've always been around your family and within the community. And if you go further away from home, they become homesick. They feel isolated in comparison to other students who may have a stronger support with peers or family members. Part of it's communication. When they've left high school with straight A's and when they've gone into a higher post-secondary, the homesickness, the isolation, and then the rigor of the academics comes as a bit of a shock. So if they have always had A's and then end up with a B, it looks like a B is a failure when it is not. Okay? And the other thing to be aware of is cultural sensitivity. There are many dialects among the main languages, among Cantonese and Mandarin, okay? The Chinese it's an ethnicity, but if you look at Asia as an entire continent, you have all the various countries, including Middle Asia. The first language that probably arrived here in the States was Toisanese, and those are the people of Toisan, all right? There I found that even though I did not grow up here, and I grew up in a non-affluent section of Washington, D.C., I found out there were 2 dialects of Toisan. When I came up here, I found out there was a 3rd. So now I'm a lost cause on translation and anything written, heard, spoken, so I can forget it. Cantonese and Mandarin are 2 separate dialects, even though it's written, but they're spoken differently. And if you have mainland China, which is main China, and then Taiwanese Mandarin, they're separate dialects. Okay, and for why we have the other parts of a high rate of suicide is there's still the old mentality of the eye for an eye and tooth for a tooth. And unfortunately, that has not de-escalated in the way it should have, considering that we all have the same commonalities when it comes to family and to excel.
Linda, thank you very much. Thank you. And thank you to our panel here. I'm sorry I didn't have an opportunity to properly greet you, but I welcome you, and I'm going to guess that you are Dr. Carrie Landa, because I already met Astria, so I'm going to, if you wouldn't mind introducing yourself, and you can offer your remarks. Thank you again for being here. Les?
Thank you so much for inviting us to be part of this important conversation today. My name is Carrie Landa. I'm the Director of Behavioral Medicine and the Associate Director for Clinical Services at Boston University Student Health Service, your alma mater,
Thank
from
you.
what I
It is.
understand. So my role is to oversee the clinical and emergency services as well as the outreach and prevention for the 33,000 students at Boston University. And before I talk more specifically about what we do in our office, I just want to give you some data about the college student population in general. There are 35 colleges and universities in Boston, accounting for over 150,000 of the members of the Boston community. On any college campus, the data essentially predicts that we'll experience one suicide in 12,000 students. So for a university of Boston University size, that's about 3 of our students per year that we might lose to suicide. College age, between the ages of 18 and 24, is an age of onset for many major mental illnesses, and that has, excuse me, a ripple effect to our community when students are living closely in housing, attending classes together, and really part of a tight-knit community. College campuses, of course, are seeing increases in sexual assault, interpersonal violence, domestic violence. Substance abuse obviously does not elude college campuses. There are several data points that indicate that there are populations among our college students, as well as graduate students, of course, that have higher risks of suicide rates, including the GLBTQ population, minority students. There is more recent data that indicates that survivors of sexual assault have a 50% higher rate of attempted suicide than their peers. In any general student population, about 10% of our students think about suicide on a regular basis as an option to escape their problems, as they describe it. 20% engage in self-injurious behavior, and we all know about the rates of drinking and substance use in college population, which is often a comorbid indicator with other mental illness. Thinking about college student population in general, the debt that they're accruing, the social pressures, family pressures, the academic pressures, and the demand that college counseling centers in general are seeing in terms of the utilization rates have skyrocketed, often referred to my colleagues as an epidemic. The pressures combined with impulsivity, underdeveloped brains, as well as the lack of resilience that we're all hearing about, the lack of coping and social engagement that we're seeing either because of social pressures or social media, has really increased the students presenting to all of our offices across the 35 colleges in Boston as well as nationally. In terms of what our office does, as well as what the offices of my colleagues do, I'm not just here representing Boston University, but other institutions in our city. We often, many of us offer clinical services as well as emergency services for all of our students in our community. The clinical services can run the gamut of individual treatment, psychotherapy, as well as psychiatry and medication management. Some of us have robust groups and workshop programs to be able to manage the overflow of students. We have crisis services that are 24/7. We manage all sexual assault, domestic violence on campus, community-based violence, so anything that really impacts our students and the student population. We have prevention services, which range from outreach and gatekeeper training programs, which really are our campus suicide prevention training programs, where on our campus we teach faculty, staff, and students how to recognize signs of distress in students, but not only recognize those, know where the appropriate resources to refer students to are. We have screening days on campus for depression, anxiety, as well as collaborations with numerous agencies across Boston, as well as hospitals, academic institutions, to have greater access for students. One of the goals is creating multiple access points because we know that only 25% of individuals on college campuses who might be struggling will reach out for help. So we want students to know that there aren't any wrong doors to go to. On a campus like BU that does have so many students, so many faculty and staff, not everyone knows that there's a center that offers support for students around mental health issues. So our goal really is to engage the community in knowing where to refer students if needed. The university conducts environmental scans to decrease any means that we might be posing to students around suicide prevention. We have threat teams when students might present a concern to the community, the BU community as well as the general community, either concerns for their own safety or safety of the community in general. We have teams that convene. That involves our Boston University Police Department to develop an appropriate plan for intervention. I actually participate in the training of our police officers for the BUPD as well as the Brookline Police Department in doing crisis intervention training to engage with individuals who might be struggling with a mental health illness. We work with the community around amnesty policies for students seeking support for substance abuse. All of our officers are armed with naloxone. Our campus health center also has it as well for any students who might be reaching out because they're struggling. Lastly, we recently launched a campaign, and because we are a linear campus in the middle of Boston that has a lot of visibility to non-BU students or faculty and staff, that really informs individuals about services, informs individuals about what mental health can look like or mental illness can look like. The intention is to really decrease barriers and decrease stigma. We have students from every state in this country as well as 25% international student population at BU. So it's really important for us to be able to inform students about how to access support, what support can look like, what illness can look like, and how to not just engage in preventative care, but intervention when needed. Thank you again for having us be part of this important conversation. BU, it's a really, obviously large institution, but we consider ourselves a city within the city, just in terms of the services that we provide and offer for our students, but could certainly not do the work that we do without the partnerships that we have with many of the folks that are in this room also represented on this panel. So again, I thank you for bringing together this group to talk about such an important issue.
Thank you, Dr. Linda. Thank you for being with us. I'd like to also note that we've been joined, I'm not sure how long you've been sitting there, Councilor McCarthy. Thank you for joining us. I don't know if you're Mr. Cahill or Dr. Henderson.
Good morning. Good morning. Thank you for inviting me to present in front of the council. It's a great opportunity. My name is David Henderson. I'm a psychiatrist. I'm the chief of psychiatry at Boston Medical Center and professor and chair of psychiatry at Boston University School of Medicine, so we know each other very well. As you know, Boston Medical Center is the City of Boston safety net hospital and has been a strong partner with the city for decades, and prior to being Boston Medical Center was Boston City Hospital. Boston Medical Center is unique in that we really care for anybody in the city. And it's an extremely diverse population, as we say that people from 70 different countries walk through the doors every day, and which means it is actually quite a challenge. And the question I often ask is, how do you develop a health system that addresses people from 70 different countries? So it's not done very easily. In the Department of Psychiatry, we have comprehensive programs. In particular, we've already heard about the BEST program, which I think is really a critical piece to what we do in the early intervention and prevention arena. The BEST program is the Boston Emergency Services Team. We have BEST and CEST. CEST is Cambridge. We also have the South Shore, but it really is the program. It's the mobile program where we can send people. We have a crisis line. People call all day and night. We can send out clinicians for evaluations, send them to people's homes. We have this excellent ride-along program where we really do need to expand. because we can have a significant impact there. We have access to two urgent care walk-in services. We have access to crisis stabilization units, so one can prevent one from being hospitalized. We can put them in this unit, get individuals back on their medicines, and reconnected to their outpatient care. In addition, the emergency services, we also collaborate with the court system, and we have a mental health court, thereby trying to prevent patients with mental illness from being incarcerated and thereby impacting their care. So people can agree to participate in the mental health court, and then we get them set up with an outpatient care program and try to prevent rehospitalization and the re-incarceration as well. Now, the BEST team really represents this acute care for people in acute crises. So, in the past 15 years, the BEST team has seen over 80,000 people. 22,000 of those have been children and adolescents. And of those, the children and adolescents, about a third of those referrals actually come directly from the schools itself. And so we know that there is a lot of stuff going on in the city, and that the BEST team is actually responding to a great deal. Now, unfortunately, the BEST team is narrow in its focus as far as who we can actually care for, although we never turn anyone away. But it's primarily funded by MBHP, so for Medicaid patients, and there's a few private vendors private insurers that pay to have access to a component, which is really the crisis line. But really, what I think that the city of Boston needs is to have a BEST program that's comprehensive and available to anyone in the city, not simply based on insurance. And so, I think that's a good starting point for us to be able to really get to the prevention of these really horrific outcomes. And so, this is something that we certainly are advocating. Now, our outpatient clinic, it's pretty comprehensive and includes, I think we get about 10,000 referrals a year, which is a crazy number, which we really can't handle. But we, as a result of this, as well as looking at our own data, and this is something I really advocate, that the use of data is actually very, very helpful. And so when we started to look at our own data at the hospital, we saw that one of the biggest drivers of healthcare costs was mental health. And not just in the mental health care, but it was also in the medical care. And so when you look at the catastrophic medical events, it was tied to mental health and substance use. And so as a result, in the strategy, the hospital decided that we needed to really address this. And so not only did we significantly increase our capacity for our outpatient clinic, but we also increased capacity for mental health and substance abuse care everywhere in the hospital. And so the notion of integrated behavioral health, so that we know that any service a patient walks into, if they, and we do screenings as well, but if they're identified as needing mental health care, there's usually providers right there that can provide it. And so we really, I tell Kate Walsh, the president of the hospital, president of BMC, that, but what we really have is a mental health hospital with some medical specialties. And stuff, but that's basically it. As you know, the population that use the hospital, many are immigrants and refugees, Many are suffering from all of the social determinants of health that everyone talks about, housing insecurity, violence, poverty, food insecurity, language difficulties, substance use, and so the hospital really has programs designed to address all of those social determinants of health, and we're trying to do it in a much more integrated way, in a sense of get people what they need when they need it. But of course, I think the biggest barrier is resources, financial resources. I'm struck when I sit in meetings where we look at the reimbursements by specialty, and mental health and psychiatry continues to be the lowest reimbursed area. Even if as a psychiatrist, I'm reimbursed at one rate. If a neurologist makes the same diagnosis, they'd be reimbursed at a higher rate. And so we've yet to achieve mental health parity in this country, but I think it's one of the key factors that's holding us back from really having a comprehensive system of care, and so that we could actually get to prevention. And I think the final thing I'll say is that we know that in New York City, they've conducted some landmark projects called, I guess, the Thrive, which was funded by the City of New York. But it really is a comprehensive approach to mental health care for the whole city, and includes stigma reduction, but also capacity building, and across the whole spectrum, teaching people to, mental health first aid, and basically how do you help somebody in distress, and rolling it out to thousands and thousands of people. So there's blueprints for a city really putting together a comprehensive plan, and I think this is something that the city of Boston actually needs as well. So thank you very much.
And I don't want to ever hear of New York doing anything better than we do here
I
in
know.
the city of Boston.
The Giants got us. We got to get them back.
There's some motivation. Thank you for that, Dr. Henderson. I'm going to assume Sean.
Yes.
Hello, Sean. Thank you for being here.
Thank you very much, Madam Chairwoman, Madam President, City Councilors. Thank you for convening this important hearing. I'm Sean Cahill. I'm Director of Health Policy Research at the Fenway Institute. And the Fenway Institute is the research, education, and training and policy arm of Fenway Community Health Center. We serve 35,000 patients. About half are LGBT, about 10% are transgender, and about 2,500 are people living with HIV. Our expertise is in LGBT health care and HIV/STI prevention and care. We integrate behavioral health with primary care and use a trauma-informed approach to care. So I'm going to speak briefly on suicide in the LGBT community, racial ethnic differences, and how to reduce the risk of suicide and how you can support these efforts. So as you note in the order for this hearing, LGB youth are nearly 5 times as likely as heterosexual youth to attempt suicide. The National Youth Risk Behavior Survey data from 2017 indicate that 23% of lesbian, gay, and bisexual youth have attempted suicide compared to 5% of heterosexual youth. Those youth not sure of their sexual orientation are 3 times as likely to attempt suicide, 14% versus 5%. Massachusetts Youth Risk Behavior Survey data from 2015 shows similarly high rates of suicidality among sexual minority youth. LGBT youth in Massachusetts are more than 4 times more likely than heterosexual peers to consider attempting suicide, 48% versus 11%, more than 3 times more likely to report having made a suicide plan, and 5 times more likely to report attempting suicide in the past year, 25% versus 5%, so almost identical to what we see at the national level. Lesbian, gay, and bisexual youth are at increased risk of depressive symptoms. In Massachusetts, LGBT youth are about 2.5 times as likely as heterosexual youth to report feeling sad or helpless almost every day for 2 or more weeks, in a way that they stop doing some usual activities. So about 61% reported this intense sadness or helplessness versus about 24% of heterosexual youth. And if these feelings of sadness and helplessness go unchecked, they can lead to serious outcomes, including a greater likelihood to report self-harm and suicidal ideation. What about transgender youth? We know that 2% of youth in Massachusetts taking the YRBS in 2015, in other words, 2% of high school students, identified as transgender, but we don't have good population-based data on suicidality among transgender youth. But according to the 2015 National Transgender Survey, in which nearly 28,000 adults of all ages took part, 40% of respondents had attempted suicide at some point in their life, compared to about 5% of the general U.S. population. 48% seriously thought about killing themselves in the past year, compared to 4% of the U.S. population, and 7% of all transgender people surveyed in this national survey attempted suicide in the past year, compared to about half of 1% of the general U.S. population. In the general population, mostly heterosexual, we see higher rates of suicide among whites than among people of color. In the mostly heterosexual youth population, we see higher rates of suicide among Native American and Latino or Latina youth compared to Black and white non-Hispanic youth. However, among LGB youth, we see similar rates of suicide among youth of color and white youth. So researchers at Pace University point out that basically LGB status moderates the relationship between race and suicide attempt. An analysis of YRBS data from several cities and states, including Boston, found mixed results. So Latino, Native American, and multiracial youth had higher rates of suicidal indicators in feeling sad than white non-Hispanic youth. Black youth had lower rates of suicidal ideation, but higher rates of suicide attempts than white youth. We did a survey here in Boston of about 300 LGBT youth of color in 2014 and published it in 2015. It was a survey we did with Bagley and Boston Glass, two LGBT youth serving organizations. We found that 40% of the LGBT youth of color in Greater Boston that we surveyed reported symptoms of depression and/or anxiety. 18% had attempted suicide in the last year, and another 12% didn't answer the suicide question. We don't have good suicide data on older age cohorts, but we do know that there are higher rates of depression among middle-aged and older LGBT people. According to the Massachusetts BRFSS Behavioral Risk Factor Surveillance Survey, about 33% of middle-aged and older LGBT people reported a diagnosis of depression versus about 20% of the heterosexual population in that age cohort. Higher suicidality among LGBT people correlates with higher levels of violence victimization, minority stress, discrimination, stigma, and behavioral health burden affecting these populations. A number of factors can correlate with better mental health outcomes among LGBT youth. These include family acceptance and school-based programming and policies such as anti-harassment and anti-bullying laws with specific enumeration of sexual orientation and gender identity, gay-straight alliances, teacher and staff training, safe school programs, and tolerance curricula such as the excellent one that the Anti-Defamation League has created. Also, openly LGBT adult role models are a resiliency factor for LGBT youth. Among older people, social isolation is a big correlate with higher rates of depression, substance use, and suicidality. So ensuring that LGBT elders can access mainstream elder services and receive affirming, culturally competent elder services is important. One intervention that's proven successful is using Older Americans Act funds for congregate meal programs for LGBT elders and their friends. We're a leader in this area. We have 23 of congregate meal sites across the Commonwealth, and 4 of them are here in Boston. So what the City Council and the Boston Public Health Commission can do, just to wrap up, first, express support for the LGBT community. The current political and cultural climate in our country has deteriorated in recent years for many groups. We've seen horrible violent attacks against Black people, Jewish people, immigrants, and LGBT people. Transgender people in particular feel under attack by ballot campaigns like the one that we just had here in Massachusetts, even from the White House, the Justice Department, the Department of Education, the Department of Defense. the State Department, the Peace Corps, which are all implementing anti-LGBT policies at the moment, and particularly anti-transgender policies. So defending the basic right of all people to be treated with respect and dignity is something that you as elected leaders should do frequently, and many of you do that, and we appreciate it. Second, ensuring that youth-serving organizations and elder-serving institutions are preventing victimization and bullying and providing affirming services and education to our population is important. So this means schools, youth organizations, senior centers. Also ensuring that these organizations are collecting data on sexual orientation and gender identity so that we know that members of our community are accessing these services at the same rate and having good experiences in them. And then finally, ensure that all government agencies are serving the LGBT community well. We published a report with the Boston Foundation 6 months ago looking at the LGBT community in Massachusetts, and we found that 15% of high school students in Massachusetts are LGBT, either by identity or same-sex behavior. 16% of 18 to 24-year-olds in Massachusetts identify as LGBT. That's 1 in 6 young people is LGBT in this Commonwealth, which is really kind of amazing. And so all agencies that are serving LGBT people, and they should be providing culturally competent and affirming care. So ensuring that all staff and volunteers are trained in how to provide care to this population is really key. And then finally, conducting suicide prevention campaigns and campaigns to destigmatize mental illness and addiction are really important. So thank you, and I look forward to any questions that you have.
Thank you very much, Sean, for your presentation. We've also been joined by Councilor Matt O'Malley and Councilor Frank Baker. Astria, would you please introduce yourself for the record?
Sure. Good morning, all. Good morning, counselors. Thank you for the chance to be here. My name is Astria Gregg. I'm a licensed clinical psychologist, and I work with Boston Healthcare for the Homeless Program. I'm the current manager of Outreach Behavioral Health there. Boston Healthcare for the Homeless Program is a nonprofit community health center, and we see the homeless population of Boston. We see patients regardless of pay, and Medicaid is our largest payer. We aim to provide low barriers to behavioral health care in particular, and see approximately 10,000 patients annually. We have multiple sites across the city. We're very well known amongst our clients, especially for the Barbara McGinnis House. This is our medical respite unit, where people are seen as a step-down level of care from inpatient level services. We also have various other sites and specialty teams, including our family team, which sees children and families across the city. The street team, which includes rough sleepers, who are those who don't sleep in city shelters and stay on the streets. We have shelter clinics across the city and various shelters, including Pine Street Inn, Boston Rescue Mission, Southampton Shelter, and various others. Some of our specialty teams are an HIV team, hepatitis C team, and our office-based addiction treatment teams. And we also have home visits. What's interesting is that a lot of our clientele are actually housed in supported housing, and so we do home visits to these persons. What's really interesting that we've seen lately is that we've had a lot more qualitative data recently about the struggles with depression amongst these individuals, and hope to assess that further. So about the homeless population, about 50 to 80% of the population in various studies have been shown to have mood disorders, whether it's depression, bipolar disorder, or others. And as mentioned, 50% of the homeless population have suicidal thoughts or suicidal ideation. It's actually interesting in that because this is such a hard-to-reach population, we don't have much more data on suicide, completed suicide and suicide attempts amongst this population. And so there's a great need for further behavioral health services, behavioral health research, and behavioral health in general for this population. In terms of our organization, we've had really increased efforts to increase behavioral health services across our organization. We have what's called open access behavioral health, or what's really just walk-in visits, Monday through Fridays in our main location in the South End. And here, any person, regardless if they've seen us before, can just walk in for a behavioral health visit. We operate in integrated primary care and behavioral health teams, and many of these teams have therapists who are either psychologists, social workers, licensed mental health counselors, and we have many interns from various schools across the city, and also psychopharmacological prescribers, including psychiatrists and nurse practitioners. And so we've also increased our depression screening throughout our organization. Standardly, people are screened annually, by primary care during their primary care visits and quarterly by behavioral health providers. However, what we've done is that we've increased our screening to have case managers and medical assistants screen our clientele with depression screens. And this is really important because these people are usually the front lines of our organization, and so they see people in the community, out in the city, on the streets, in various clinics and in various shelters. And so to have the case managers be able to assess our clients and patients for depression can really help reach this population that is very hard to reach. We've also, speaking about the BEST team, are going to have trainings for the case managers on how to use the BEST team, which is something that is unique that we are doing. Another thing that is really pertinent to suicide prevention is substance use, given that comorbid substance use disorder with mood disorder can really increase the chance of suicide amongst this population in particular. We have a very interesting and sometimes controversial program called the SPOT program. This is a supported place for observational treatment, and it is for persons who are actively using opiates. It is our answer to the opiate epidemic, which disproportionately affects the homeless population. What's interesting is that in approximately 14 visits, persons who attend our SPOT program will be connected to care. This may sound like a lot, but given that this is a very hard to reach population, this is actually something that we're pretty proud of. These individuals may not typically be connected to behavioral health care or care in general. Because of the success of this program, I'm also tasked with opening another program similar to the SPOT in one of our shelter organization partners, the St. Francis House. The SPOT program hopes to have another recovery coach and harm reduction specialist in order to work closely with our multidisciplinary treatment teams and further engage our clients to services. Lastly, we have really a unique and interesting endeavor that we're trying to help our staff to reduce burnout. We have a new consulting psychologist that is providing emotional support just to our staff. And this consulting psychologist visits our clinic, our main clinic, every week to provide services just for our staff who may be at risk for burnout, who have recently encountered a really stressful or anxiety-provoking encounter with one of our patients or clients. We're also hoping to increase the service to our shelter clinics as well. Lastly, because Medicaid is our major payer, we are really hopeful that agencies through the city and state will help us to further increase the opportunity to provide Medicaid for this very, very vulnerable population. And thank you for the time to be here today.
Thank you. Thank you very much for your presentation. I do want to just appreciate the efforts that you are undertaking to reduce staff burnout. I think that we need that across all industries. We talked in length about some of the services that the Boston Police Department is offering, and we talk about what's happening in the Boston Public Schools, and we also know there's a shortage of mental health professionals across by institutional design because of the expense, because of the cost, but also because of the lack of providers sometimes. So providing those support services, I think, is key internally, because if those providers are burning out, leaving that work in particular or going into private practice, changing their workload, then individuals aren't able to access those services anymore. So I'd like to just thank you for that and recognize that effort. Estrella, can you just talk a little bit about your comment about the 14 visits, the individuals who use the SPOT site are then entering into behavioral health programs?
Sure. We're actually just beginning to analyze this data, so we don't know too much about it. But basically, as I mentioned, this is a very hard-to-reach, vulnerable population, a population that doesn't often come to our clinic. The visitors that come to our SPOT program are really different from the population that sees our clinic on a regular basis. And so this is a really particularly harder-to-reach subset of our population. And so many people will see our harm reduction specialists that we have and our nursing staff that we have in our SPOT clinic in our main location, and we'll have these brief interactions with our staff and our organization, and hopefully what they do is have really open-armed and really lack of a pressured experience. And so a lot of organizations may may act in a different manner where people might be pressured to seek services that don't have so much of a harm reduction approach that we have. And so we really try to have a harm reduction approach where people are just coming in and we take them as they are. There's no judgment. There's no obligation or responsibility that they have to have. They can just come as they are. And so with this low threshold, we hope to have more and more of these difficult to reach persons come in. And we've seen that about after 14 visits or so, they eventually want to seek our services. And of course, all along the way, our harm reduction specialists and nursing staff are really encouraging these individuals too in a very gentle manner.
Great, thank you. I appreciate you adding to that. And so generally for all of you, I'm going to ask just sort of one question. If you want to respond, please do, and then I'll open up to questions from my colleagues. You know, one of the challenges, I think, whether it's insurance or lack of providers is, forget stigma. We know that that contributes to people not accessing services. But can we talk a little bit about some of the other barriers that you're seeing in your organization specific to people not accessing services? You know, I don't know, at BU, is there a wait list? Is there, you know, are students able to access those services? And in particular, are off-campus students also able to access those services? It'll come
All of our students are eligible for services, even part-time students. Students that are part-time and don't have or subscribe to the student health insurance have more limited access. However, we don't turn anyone away for an evaluation, and definitely not for crisis or emergency services. For mental health, every one of our students are seen within 48 to 72 hours for an initial evaluation, which compared to access in the community is a much quicker turnaround. We have the unfortunate time crunch of living on semesters of 13 to 16 weeks, so a 4-week wait for a student could feel like eternity. That initial evaluation is a 20-minute evaluation by a licensed clinician that does a risk assessment, safety planning, and that can have a disposition to a number of different things. It could be internal to an intake with one of our prescribers or therapists. It could be to our groups program. It could be to our emergency service, which would further assess the student and assess if a hospitalization is needed or safety planning is needed. And sometimes it's actually not even for mental health that a student is coming in, but with an institution as big as ours, sometimes students just don't know where to go. So it could be that they actually need something as easy as time management, for example, and we just refer them to the appropriate office on campus. But we really work as a clearinghouse in some way for a lot of those issues that might arise. In terms of barriers, though, you know, at one time there was a 4 to 5 week wait, which was a major issue, and we changed our model to be able to accommodate the demand that we were seeing. But in terms of other barriers, students are really fearful that information is not confidential. We are bound by the same confidentiality that any healthcare provider is, despite being an academic institution that is governed by FERPA, the Family Education Rights and Protection Act. We are a carve-out of FERPA, so we are not under FERPA. We follow and comply with HIPAA guidelines, just like any other healthcare provider. Our ethical and licensure guidelines dictate that we can't breach confidentiality unless there's any sort of emergency. So really having students understand that we are confidential is really important, and then them making the time to come in. BU students, I know in particular, actually spend more than average, compared to the national average, in studying, in doing academic work outside of the classroom, higher than the other Reds across the river even. So because it's a highly academic focus at the university, students don't want to make time to take care of themselves, which us really encouraging prevention and the links to academic success is another really big push that we're engaging in right now.
Thank you. Sure. Yeah, please. Thank you, Dr. Henderson.
And, you know, as you pointed out, you know, stigma and, you know, plays a huge role, but we have pretty open access. And so we can see most people within 3 days of referral. But our biggest problem is the no-show rate. So we give them an appointment, but only 50% will. I think the numbers were, we went through this, of 100% referred, 50% will have contact with 80% to get them an appointment. And then we have an orientation group where they come and we teach them about the service. And so the rate drops down to 50%, and by the time we actually see somebody, we're down to like 30% of those who were referred. And we don't know that other 70%, they may show up again, or they'll end up in the emergency room or something like that. So our biggest issue is really the no-show rate. And people will tell you it's, some of it is finances for them, like how do they get there? They don't have money for the bus or things like that. Or they have to make tough choices, or they don't have, child care. And so there's like real life problems that prevent people from engaging in care. And we try to, once we understand those problems, we try to address them and get them travel money and things like that. But what we don't know, we can't fix what we don't know. And when they don't show up, then they're just out there still in the community. And I think the other aspect is that again, if you bring back the cultural aspect of we have a system where we say, here's your appointment, you come, you see this person, and so on. But many people have been, received health care from their home country, which was very different. So they would only go to the doctor when they were really sick. They wouldn't have an appointment. They would just show up and wait all day until they were seen and things like that. So there's some clear cultural differences that as a health system we're trying to understand. How do we engage people who aren't used to interacting with our health system in the way that we've built it? And so we have to get out more into the community and so on to try to get people in. So.
Thank you.
I would say in Massachusetts in general, lack of insurance has not been a barrier to accessing care. We provide a lot of free care and sliding scale care as well. And we have near universal insurance coverage, but I do think one of the things that the federal government's doing where they're going to penalize immigrants, legal immigrants and undocumented immigrants for using, under the so-called public charge policy, they're going to ding them for using WIC and using other health care and other kinds of services. That could cause immigrants to not seek health care that they need. And we're concerned about that and keeping an eye on that. One thing that the LGBT community does struggle with sometimes is finding culturally competent and affirming mental health services. So, for example, we run bereavement groups for older adults who are LGBT, and one of the people who came to us recently was told that he could participate in another bereavement group, a more mainstream one, but should not disclose the sex of his spouse who he had just lost. So that was kind of ridiculous, and that still occurs. Veterans services are very important. The VA provides health care, provides housing assistance, job assistance, suicide prevention work. And we know from in our community, we're actually as likely to be veterans as the straight community. There's data from the BRFSS that show that that's true for middle-aged and older LGBT people. About 10% are veterans versus 11% in the straight population, and the difference is not statistically significant. But because a lot of gay people were drummed out of the military and given dishonorable discharges, a lot of people don't know they're eligible for the services, or they may have to do something to be able to access services. So that's important, I think, to know that here in Boston and across the Commonwealth there are veterans. And the last thing I'll just mention is we have really great school-based programming here in Massachusetts, here in Boston, for LGBT youth. But we also still have conversion therapy going on and ex-gay therapy. And we had a bill in the legislature that would have prohibited that for youth, for adolescents, and that was not passed on a technicality back in June, and hopefully we'll be able to get it passed this year.
Thank you. Thank you all. Councilor McCarthy.
Thank you very much. Madam Chair, I just have a quick question for Dr. Henderson. You had mentioned the Thrive, and of course when you mentioned New York, my ears got perked up too. Is that a state-based program or is that a city program?
It'll come on. Trust it.
It's a city program, and would you happen to have, I mean, I'll do some research in it, but do you have a colleague there that would be willing to have a chat with us? Cool.
Absolutely.
I'll
Yeah,
grab you later.
I think it's one of a kind, but it's comprehensive. I don't know how they're funding it, but the city is funding it. They've probably got some good donors and stuff. But it's a pretty comprehensive program.
Thank you very much,
really
Doctor.
designed to integrate it all.
Yeah, if you could follow up with the chair on that contact, we'd certainly like to reach out.
Sure.
Thanks.
Absolutely.
Thank you. Councilor Baker.
Thank you, Madam Chair. Just a couple of questions. I didn't quite get your name. Astria Gregg. Thank you for coming in today. Can you explain to me how your how do you interact with the best team? Like, how do you deploy them, or do you deploy together?
I think it really varies across our multiple, our various teams, and we have various clinics across the city, so every clinic operates in a pretty different way. But we use the best team heavily. As mentioned, our case managers will really rely on that because they're not clinicians themselves, so they have less of a familiarity and confidence with, talking with and discussing with some of their homeless patients who may be endorsing suicidal thoughts. And so they'll heavily use the best team, and I encourage them to do so when I provide them with trainings. As for our clinical staff, we'll often Section 12 or call the best team as needed, depending on the availability of clinic staff, whether or not someone is able to walk someone to a crisis community stabilization unit or emergency department nearby. So it really varies on the clinic that the patient is seen in.
Okay. So interactions every day, and then whatever the situation is, this is how we deploy.
That's right, yeah.
Okay. And will you talk a little bit about the spot? You said,
Yeah.
for the most part, the spot are people that are not necessarily coming through your doors
That's
every
right.
day? So where are they coming from?
So they're coming from the street, so just to provide some more education about that. So people who use the SPROC program, the Supported Place for Observation and Treatment, they use opiates, heroin, or pills outside of our walls, outside of our clinic walls. They've already used, and they come into our clinic where they're safely monitored by our nursing staff and our harm reduction specialists as a means to reduce overdoses. So if anyone is showing signs of overdose, then they're monitored more closely, and if they need to, then they are quickly sent to a nearest emergency room so that we can prevent deaths and more.
Yeah, so would you need to send them to the emergency room if they're in the spot? Can't you?
No, not necessarily. A lot of
Yeah.
times, a lot of our clients that come to the SPOT program will just come to our program and they'll stay there. And as their high wears off and they're safe to be discharged, which is monitored by our nursing staff, then they're let go. And as mentioned, that we provide them with a lot of education on our services and try to really encourage them in a gentle and not pressureful manner to engage with our behavioral health and substance use services in particular.
So I know it's a difficult population.
Yeah.
Have you been able to figure out how many people may, after being in the spot for a couple times, do we have numbers of who may go from the spot and then look to get some help, look to get into treatment?
Yeah, we're just doing some initial observation of that data, and we don't have much to share, unfortunately, yet, but we're very much interested in looking at that data. What we do know so far, just qualitatively, is that this is a real population that's real hard to, once we got them engaged into our behavioral health services, really hard to keep them there. And not just behavioral health, but also our OBAT team, our office-based addiction treatment teams. It's really hard to keep them engaged, and so what was really important, again, is our harm reduction specialists and our case managers. They are really wonderful because they're at the front line, often meeting these individuals in the community, on the streets, or calling them and really encouraging them to come into our clinic to see our providers, to see our healthcare professionals.
So are these people that are using the spot, are they maybe more on the front end of their, for lack of a better term, their journey? Are they just
Not necessarily,
because
no.
they're more difficult to reach, they want to continue with that?
They're not necessarily in the beginning of their addiction. They're people in all sorts of, stages of their addiction that we see.
All the different spectrum.
Correct,
And
yeah.
is it, do you have a sense of like how many people have used it, and is it repeat, is it the same
Sure.
people that are using that
I don't have that data on the top of my head, but that's a very good question. So a proportion of them are people that repeat, who come into our clinic over and over again, but we do have people who will just use our clinic 1 or 2 times and not again.
and then you never see them again?
Exactly, yeah.
Okay, thank you. Thank you, Madam Chair.
Thank you, Councilor Baker, and thank you to this panel very much for your insight, your information, and I think most importantly, the work that you all do every single day when you're not before the City Council. Thank you very much for being here. And just, I'm going to be quick as opposed to properly thanking my guests. I'm going to move on to our third panel, just because we're getting late into our testimony here. So we have Steve Mongu, who's the Executive Director of the Samaritans, David O'Leary, who's from the American Foundation for Suicide Prevention, and Jen Leggett, who's the Director of the Leggett Group. Thank you for being here. And then following this panel, I only have one more person, Brandy, for our public testimony. Did anyone else? Okay, so we've got another sheet. I'll make sure to grab it after the next panel. Thank you to the three of you for being here. Jen, do you mind if I start with you? We've been going from my right to left this morning, so we'll
Great.
continue with it. I do want to actually say before Jen speaks, I think just after I took office, Councilor McCarthy connected us, and we talked a lot about accessing mental health services across the city and for our residents. And I'm happy that this conversation still continues, and I'm really very happy that you're here with us today.
Thank you.
Thank you.
I really can't thank you enough for your leadership on this, Councilor Sabi George. All honorable city councilors, esteemed fellow speakers and truth tellers, and concerned residents of Boston, thank you so much for having me here. My name is Jen Irby-Leggett, and I'm a licensed independent clinical social worker. I speak to you today in my capacity as the proud owner of the Leggett Group, a small business which is an outpatient private behavioral health practice in Rosendale, where we serve 350 residents each week with psychotherapy and now psychiatry services. Of note is that while we are a private practice, we contract with a wide array of insurances, and we do have 2 Medicaid contracts, and work closely with the community health centers in our neighborhood. I'm also a proud clinical social worker and speak as a volunteer for NASW Massachusetts, a subgroup of which I surveyed for inclusion in today's comments. I also lead a group of perinatal clinicians around Boston who I also surveyed for inclusion in today's comments. I last had the honor of speaking in front of the City Council in May of 2016 when we spoke of mental health and substance use disorder services. I presented concerns about a lack of access for residents and city employees due to the lack of providers who take health insurance in the city. I wish I could say that things have gotten better. In fact, I come reporting the voice of the outpatient providers saying strongly that things have gotten worse in just the areas that you seek to address in your hearing order today. To summarize the comments of my colleagues within NASW and within the group of Boston area perinatal mental health clinicians, we need your help and we need it fast. Our biggest concern, the quickly dwindling number of psychotherapy appointments available across the city, due in large part to settings that previously provided a lot of therapy, making the decision to stop doing so at the numbers previously done. These decisions seem to be driven primarily by the economics of healthcare, and I truly appreciate Dr. Henderson talking about rates earlier, because it's not something a lot of people want to take on. Behavioral health reimbursement rates remain historically low, some not being raised $1 in over 15 years, and more and more providers leave health insurance panels daily, leaving fewer and fewer appointments for residents seeking care. So while we have high numbers of well-trained and licensed providers in Boston, more and more of them take no insurance or hand-select those that pay a close to respectable wage and with the easiest terms of work. As a practitioner who has remained committed to seeing clients from a wide range of socioeconomic levels, this is frustrating, as it further reduces the numbers of seats available for therapy for people. As a compassionate person who is aware of market forces, I'm also sympathetic of the fact that people need to pay their bills as well. Behavioral health treatment has consistently shown conclusive evidence of beneficial effects in decreasing people's suffering and reducing the overall healthcare spend for complex medically and psychiatrically involved patients. Therapy can truly help in powerful ways, often very quickly, and when some people in the city just can't access it, it is truly sickening. Providers I speak with are concerned that there are not enough services for all of the following people: new parents, especially those facing postpartum depression and other perinatal issues, non-English speakers, low-income folks, people who are homeless, people coming out of incarceration, folks with major mental illness, children and teens with anxiety and behavior issues, immigrants, people with bad insurances like Mass Health, people requiring psychiatry, LGBTQI people, people of color who deserve to have someone who looks like them sitting across the room from them, folks with challenges in geography and poor transit, folks who have a difficulty paying higher copays, folks who have difficulty juggling costs of living, especially with kids, and making time for treatment. I'm not sure there's anyone I've left off that list. This group of clinicians wishes for enhanced services in the city to include more representation of difference and language in the provider community, more allied support services in doctors' offices, additional child psych beds, increased training around socially just and competent cross-cultural services, increased support and advocacy for people needing DTA assistance, and a severe increase in affordable housing, issues many of you work on all the time. The specific request that these clinicians are making of the City Council is a strong action in addressing reimbursement rates in Boston so that providers can afford to accept insurance, easier access to high support services that would keep stressed, low-income families housed, and easier access to emergency services. Reimbursement rates really matter. They matter because the historically low rates paid to behavioral health providers lead whole hospital systems to eviscerate their therapy services because it is more profitable to have a higher paid medical specialty or even a nutritionist who has the same master's level of training as me but receives 3 times the compensation from insurance that we behavioral health providers do in that office suite. They matter because people are not able to get psychotherapy in their doctor's offices as they have in the past, which was an important safety net for people with complicated psychiatric histories and who need and deserve extra support and an appointment with no cancellation fee attached if they miss the bus after being kept late at work. I do believe that an alarming and quiet shift has been happening for years now, in which some, not all, large primary care settings are eliminating or reducing their own capacity to deliver mental health services out to the community, as it is a money-losing prospect for their organizations. The problem is, in my mind, isn't that the responsibility of a primary care setting that treats the whole patient, especially in a state that has a clear parity law requiring the same care for a medical or a mental health problem? Shouldn't they be required to retain the capacity to treat the full range of mental health issues of their patients, mostly within their own walls? I started out my own solo practice on Marlborough Street 15 years ago, seeing 27 people per week. I grew that capacity 6 years ago in Rosendale to what is now the Leggett Group, a practice that has grown to have the capacity to see 350 people per week. I just texted my office manager. She reports as of 20 minutes ago that we currently have 4 appointments available in my office. We are pretty full. Last month, we signed a lease to create another 350 appointments per week in progressive Framingham, where the city's leadership is as active and involved as you all are. I have found that the outpatient group practice is a pretty solid business model. We can see a large capacity of people in an outpatient setting that is not attached to a hospital emergency room or MRI machine. We keep costs low, and yet I do struggle to compensate my staff adequately for the very difficult work they do due to low insurance rates, even with the ability a group practice has to possibly gain access to higher rates with some companies. However, we cannot see the sickest patients who should be in a setting with a team of psychiatrists or MDs available and in which they can be rehospitalized easily. Those patients have fewer and fewer options each day. I see a lot of trends and have listened to a lot of people calling with their biggest concerns about their most precious people. And I'm telling you that someone needs to be measuring how many seats there are for therapy in the city and who is cutting the ones that their institution does not want to lose money on. The new smart trend of embedding clinical social workers into primary care settings is wonderful. However, the efficacy of that plan is dependent on having other clinicians within their own settings to refer patients in need to. When this does not happen as a pairing, we see the acuity rising dangerously in our own offices. Cutting psychotherapy services for the sickest people while moving social work clinicians into embedded roles together is not progress, while many people are calling it that. We are seeing the same trend in IOP settings and psych bed settings. And so in the absence of availability for that, very ill people are calling to get a once-a-week therapy appointment in my office. Not the right match for someone who is acutely suicidal and needing round-the-clock care, despite our efforts to include as many people as we can. As a result, I have invested more money in our screening process, making sure that the patients who call in more and more distress are indeed the right match for the skills we have to offer, and to spend the time helping connect them to services that they do need, even if they're not with us. I only see this getting worse and with greater risk for our resident population just trying to get care for their loved ones. The saddest result? It's a tough question to answer. But the call that has most disturbed me in the last year might surprise you. It's not the ED boarding call about a 13-year-old who was boarded for 9 days as there was no psych bed for her across the state. It's not the mom I've spoken to multiple times over the past few years, desperately trying to find compassionate care for her mentally ill, violent, precious son just released from prison. It's not the request from my staff for assistance in rehospitalizing a client who came to us for an intake after being discharged from an inpatient unit without a step-down program in between, requiring 4 hours of staff assistance, for which we get reimbursed for 1.5 hours. It's the single mom with an accent in her voice who called this early October. This mom was calling with an ideal behavioral health request for assistance. Her 7-year-old, previously happy-go-lucky son was suddenly coming home from school with reports of serious behavior choices in school, and she wanted him to get help. She was willing to take the bus anywhere for him, and she'd heard good things about my office and would bring him here from Dorchester. We don't see kids as young as 7 and didn't have any available appointments, so I went through my directory of colleagues and gave her 4 names. I also suggested she call her PCP, which brought the most troubling answer. She had spoken with her PCP's office at her large medical group, and they told her that they could see her son in April for an intake. She was calling in October. When she begged for something sooner, they told her they'd give her a phone screen in February, and that they were booked out in what I know to be their recently reduced small capacity behavioral health system. Half a school year gone for what any clinician knows might be the kind of brief treatment success that may have gotten this young boy back on track in school by solving whatever sudden problem he was having. I told her that if none of my colleagues could see her son, that she should call me back and I'd help her find someone. She thanked me for my help and asked if I had any other ideas. I suggested that she should call her city councilor, her senator, and perhaps even the attorney general. This mom was shocked that I'd suggest that, but then said, "I can't tell you how much it means to have someone take me seriously. I'm almost crying right now." I'm also going to ask you all to check your assumptions as you listen to this story. Her insurance, Blue Cross Blue Shield. Her healthcare system, not a strained community health center, but a big private one that you likely go to yourself. This is a call that keeps me up at night. I wonder how that boy is doing today and if he got services. It's not good enough, and it's not fair to our city's residents. Thank you for your time, and if I can do anything to help with any of this, please call me.
Thank you, Jen. Thank you very much. David, welcome back.
Thank you, Madam Chairwoman, Councilor Asabi George, Councilor McCarthy, and Councilor Baker. Good to see you again. I am here on behalf of the American Foundation for Suicide Prevention, the Greater Boston chapter of AFSP. We are a national organization that works to prevent suicide and to bring hope to those who are impacted by suicide. I should add, it's been incredibly rewarding to be here this morning to hear the challenges in many cases, and in some cases successes, of our partners, community partners who work in this same space. AFSP had the opportunity just a couple of months ago to present some of our prevention programming before the Boston City Council. And in talking with the council at that time, I remember being impressed again with how connected we all are to this issue, all of us. We all know someone who struggles with mental illness or worse, has suffered a loss to suicide. AFSP as a national organization has chapters, 80 of them in all 50 states, including our Greater Boston chapter, which I represent. That's our oldest in the organization. We serve who we serve through 4 main areas. Through research, we are the largest nonprofit funder of research in the country, funding over $5 million in grants to learn about causes of suicide, warning signs for suicide, and prevention programs. We also have an advocacy program. We converge on Beacon Hill here in Boston each year and on Capitol Hill in Washington, D.C. each spring to advocate for support for our work. We are already working with the statewide coalition and the Department of Public Health and would appreciate the council's support as we lobby for funding and support for education programs and initiatives, not only as they pertain to overall prevention, suicide prevention and mental health in society at large, but more specifically for students and for schools. It's worth noting, I think, and it's been said in other ways this morning, that when it comes to major health crises, as a nation, when we spend money on research, we see results. So in the past 15 years, we have invested a great deal of federal funding to research causes of death for things like heart disease, HIV, AIDS, prostate cancer, and other diseases and illnesses. And as a result, we have seen made major progress to see major reductions in mortality rates. That has not been the case with suicide, and as has been pointed out, the rates have not decreased over the years for suicide. In fact, in many areas of the country, they have risen. In fact, it's been a roughly 3% increase in the rate of suicide nationally, 44,000 to over 47,000 in the most recent CDC report, which was just released last week. Further, AFSP offers support for survivors and those impacted by suicide. We have a survivor outreach network which puts those who have experienced a loss to suicide in touch with a trained AFSP survivor who has suffered a similar loss. We also host the International Survivor Day here in the greater Boston area throughout Massachusetts at various satellite locations statewide, across the country, really across the world, to bring support to survivors and draw attention to this important public health issue. Programs are another area in which AFSP offers suicide prevention. We have a handful of programs. We were speaking a little bit earlier from the counseling director at BU noted there are 150,000 college students here in the Boston area. We have a program specifically for college students called It's Real, College Students and Mental Health. It's a film designed to raise awareness about mental health issues that are commonly experienced by college students. It's intended to be used as part of an educational program to encourage help seeking for college students and awareness about the issue. AFSP has produced a number of videos in our Voices of Hope series, which is a series of videos that features individuals that have struggled with mental illness and suicidal ideation to speak about their own personal experience. There's a program called Talk Saves Lives, which we were fortunate enough to present for the Boston City Council about a month ago. It's like a 1-hour, almost a Suicide 101 program that introduces the topic, how to speak productively and in a healthy way about suicide and mental illness, warning signs, and some prevention techniques. We also offer this presentation in various modules, including one directed toward the LGBTQ community, firearms, seniors, and other at-risk and targeted communities that may be at higher risk for suicide. A program that we're most proud of is our IFSP. It's an interactive screening program that it's an online program that AFSP offers. It's a confidential screening program that we make available to partner organizations like the Boston Police Department. We're extremely proud of the partnership with the department and the Boston Police Foundation, basically to help identify those who may be struggling, those who may be at risk, to get them connected to services before crises arrive. Even when people know about mental health services, as police officers and law enforcement officials certainly do, shame and fear and stigma and embarrassment often prevent them from seeking help. With this confidential program, we're looking to change that. We're proud to be presenting this partnership that we have with the Boston Police Department at our National Leadership Conference in January as a model to hopefully duplicate in other cities with other chapters and with other departments. The link between elevated risk for suicide and with police officers, as well as law enforcement and veterans in general, has been well documented and spoken about this morning. All of these programs, Talk Saves Lives, It's Real, our ISP, we offer free of charge to schools and businesses and the community at large. They are available free of charge to anyone who is interested in raising awareness about suicide and the importance of mental health. We also work in partnership both on a national level and locally with various organizations, and here in Massachusetts, contractors in the state, to provide more involved trainings, including Safe Talk, which is education for the community to identify and encourage individuals to become suicide alert helpers, Assist training, which is applied suicide intervention skills training, adult and youth mental health first aid, which was mentioned a little bit earlier. Our staff and volunteers are trained in delivering this program. Our organization offers 7 statewide Out of the Darkness walks each fall, including our Boston Out of the Darkness walk, which took place right out front here on a rainy Saturday about a month ago. It brought close to 3,000 participants there to raise money and raise awareness about AFSP. We host 10 campus walks at area colleges and universities each spring to help bring our message to high school and college students. The walks continue to grow each year. which I believe speaks to the growing number of people who are connected to our work, who are impacted by this mental health crisis, and also about their willingness to be open about talking about it and dealing with it. Stigma has been mentioned several times this morning in a few different contexts. We believe, AFSP, that removing stigma surrounding suicide and mental health in general is so important to our work. We're extremely proud of our partnership with the Boston Police Department and the Boston Police Foundation. Commissioner Gross, who has been incredibly supportive of our work and understanding of the importance of it, has said it very well. He says it over and over. It's okay to not be okay. The connection between our physical health and our mental health is real and a very important one. And I believe that goes for all police officers, for veterans, for high school students, for city councilors, all of us. When we have an open and honest conversation about mental health without judgment, without stigma, we've come a long way toward helping those who struggle with mental health issues, as well as saving lives. Thank you.
David, thank you very much. Welcome, Steve. Thank you for being here.
Good morning. Glad to be here. I'm Steve Mondro, the Executive Director of Samaritans, and Councilor Sabi George, thank you for coordinating this, and thank you for joining us this morning. My story actually begins with losing a childhood friend, a next-door neighbor, a college classmate, my wife's cousin, the father of the maid of honor at our wedding, 2 work colleagues, and my brother-in-law to suicide. With the most traumatic loss I suffered being my sister Kathy many years ago. 18 years after Kathy's suicide, my oldest daughter wrote a story titled "The Day My Daddy Cried," recalling that day from the perspective of her 4-year-old self and sharing how my screams had frightened her. The trauma of suicide lingers with survivors. I often think that if I knew then what I know now, I might have listened to Kathy more closely and heard her pain. But it's not the loss of Kathy and so many others that make me so passionate about Samaritans and the mission to eliminate the incidence of suicide. It's really the hope that the organization provides each and every day in our communities that attracted me and has kept me engaged. I volunteered with Samaritans for over 10 years before joining the staff 4 years ago, but I will never be able to give back to the organization the gift that they have been to my family. For those of us who lost a loved one to suicide, the complex grieving process can be so overwhelming. At Samaritans, we serve survivors of suicide loss through personal visitations and peer-facilitated safe place meetings. We had over 1,200 participants last year, with one lost survivor sharing that it was like having a life preserver tossed out to me when I was drowning, capturing the essence of our meetings. We also helped people identify risk factors and warning signs of suicidal behavior with over 17,000 attendees at our workshops and community events last year. We completed suicide prevention workshops in about 1/3 of the 9th grades in the Boston Public Schools, and it is our hope to ultimately hold annual workshops in every high school in the city. And we coordinate with other organizations, so I want to really be sure people understand. We work well with Sandy Hook Promise, and the best thing you could do for the high school years is have a program every year for their 4 years, so there's 4 touch points for structured suicide prevention workshops. We've also delivered workshops in the Boston Public Health Commission and elder care centers with the street workers and to many other city staff, as well as organizations across the city, including the staff of the Boston Red Sox. Our workshops have also been incorporated into the Simmons College Graduate School of Social Work program and Northeastern's University Nursing School. We've had nurses at Boston Children's Hospital share that they had never had trainings like what Samaritans provided, and they'd put what they learned into practice. As noted in the quote on the slide, learning not to be afraid to ask someone if they are feeling suicidal can save a life. But Samaritans is best known for supporting the statewide helpline. We have over 300 volunteers answering the phones for calls and texts and they've donated close to 30,000 hours serving the tens of thousands of callers and texters to our office. You had mentioned the numbers earlier. 877-870-4673 is the statewide helpline, and it wasn't until around 2004 that we were able to share that number. And if you do dial 800-273-TALK in Boston, the call will get routed to Samaritans. So we are one of the 160 crisis centers that answer calls on that number. So next, I hope this will work now, we want to play a video clip of a text. And I'm hoping Nadine can help me with this. There we go. So I'm sorry if the font was hard to read in some places, but you were looking at that from the seat of the volunteer. And it's not uncommon that we get a call or text like that where we're basically being told, I'm going to end my life by suicide. And we know that we need to give power to that individual regarding the next step. You might have noticed the comment from the texter was, don't call the police. I don't know about you, but when I watch that minute and 30 seconds seems to take forever. It was actually closer to a 4.5-minute period of time that our volunteer was staying engaged and letting Jesse know that we were there, listening, ready to help. Jesse did agree to receive help, and we were able to send an ambulance through that night. And as stated in the research, when we interrupt a suicide attempt, we do, in fact, save a life. With the way our organization works, we really depend on individuals. We are a 501c3, so we raise all of our funds locally. Over half our donations come from individuals. We get support from foundations and also some support from DPH in the state of Massachusetts. But what can all of you do to help, to fill the gap? Plaster that helpline number throughout your facilities, on your bulletin boards, on your websites, in your communications with your teams. Make sure you go to SamaritansHope.org to explore scheduling a free suicide prevention workshop, and tell your family, friends, school groups, houses of worship, and any community group you're involved in that they should have us in to do a free suicide prevention workshop on site. And every clinician should let their clients know Samaritan's free helpline and grief support meetings are available to supplement their treatment. They can reach out to us, as did one teen after a workshop at a Boston public school, stating he was going to overdose that night, but thought instead he'd try the number on the wristband the lady gave him who came by his school. He agreed to contact us again before our conversation concluded that night. So if you believe that people can help people, then you're eligible to become a Samaritan's volunteer. Explore joining our diverse team ranging in ages from 16 to retirees in their 80s and working professionals, most all of whom say volunteering has been one of the most rewarding experiences of their lives. You and your friends, neighbors, and relatives can be there to let others know that they can be accepted for who and what they are, that their feelings are valid, and that at Samaritans, they won't be judged. So please, share the treasure of your time and save lives with us. Thank you.
Steve, David, Jen, thank you very much for your presentations today. Steve and Dave, the information that we heard earlier today about the demographics of those that have a mental health crisis, have suicidal ideations, are those demographics matching the phone calls that you're all getting or the other communication that you're all getting?
Well, I can speak to AFSP in terms of research shows that, yeah, they match. It's rather fluid, too. They come, they go. There are certain demographics at times that are higher. I know Steve and I are in the middle-aged, white, male demographic, which currently is spiking at elevated risk for whatever reason for suicide. So it can be rather fluid. It does move around just a little bit, but certainly those, as we spoke of a little bit earlier, law enforcement, veterans, college students. There's a demographic in college students that are at elevated risk for suicide. You may be able to speak to in terms of phone calls, the calls that you're getting.
Yeah, I could share that, by the nature of what we do, we keep every call anonymous and confidential. That being said, we're dependent on the volunteers in that exchange to identify as best they can the demographics of the caller or texter. So if in conversation an individual mentions they're going into the high school, we know it's a teen of that age. Based on that collection, over the vast majority of callers are middle-aged white men, so it aligns very well with the need. We know that over half the texts are coming from people under the age of 30, which makes sense. So that's why we're so excited. We're the only number in New England that you can call or text the same number and get the same service at the other end of the line. So we do see an alignment with the need in the community with the service that they're choosing.
Then what about the role of social media, especially thinking about that demographic? I think somebody recently, and I don't know if it's because we were preparing for the hearing, but I have seen an increase on my social media feed for some advertisements about, I don't know which organization it is now off the top of my head, but it's
It was probably Samaritans. Come on now. We were
AFSP, yes. We work together. Yes, we do. But the social media piece is interesting because the social part of social media, for a lot of kids, I think I've got kids who are just out of their teens, and they've got all kinds of social media accounts. A lot of them I have no idea what's going on. They got the one I can see, and of course the one that I can't see. I think there's a responsibility for us to try to be vigilant in terms of our children and seeing what kind of communicating that they're doing on social media that may open our eyes or may cause us to suddenly say, geez, do we need to intercede here? Is there somebody who may be at risk? I would say at the same time, generally speaking, it's my opinion, anecdotal, that for so much of the language that we use about when we talk about mental health and when we have these conversations about suicide and mental health in general, our kids are so much further along in being able to talk about this stuff in a way that certainly my generation wasn't at that age, and I think people older than me may not be. They're over having to be hung up about a lot of this, and I think that gives me a little bit of hope for the future.
Yeah, and I'd share this last year was the first time we were actually deployed a social media strategy, and we have seen a clear increase in connecting, especially with younger people. And because we're in high schools every week, they're telling us where we really need to be. But the reposts, retweets, we measure all those things like others now, and we can see it through younger people, especially about the text number. And we have a rotation. Some's informational, some's awareness raising, some's about specific events. We also see it contribute. We ask every volunteer applicant, where'd you hear about us? So they're seeing the social media and coming into the organization. Also the MBTA ads, for those of you, I hope you've seen them. They're on the buses, they're in the stations, on the trains. That is a huge vehicle for the greater Boston area, getting our number out there and helpline.
Great, thank you. And then Jen, you certainly gave a very passionate plea for some of the changes that need to happen within the healthcare system to support those that are in crisis. and not in extreme crisis, but if they're waiting from October to April for support services, they're likely going to be in a more extreme crisis. Can you just talk, just very briefly, about the changes that need to happen with the reimbursement rates?
So, when an independent clinician contracts with an insurance company, they are not able to collectively bargain with insurance companies. It's just a one-to-one relationship. And over the years, behavioral health reimbursement rates have stayed the same when medical specialties rates have risen astronomically. I think it's due to a number of factors, including the fact that we're a fairly privileged group historically that has sometimes had sponsors sort of defraying the draw on our collective family households. We can afford to make less because maybe a partner makes more. Those days are over. People need to be paid for the work that they do, and people need to be paid fairly. So I think that medical specialties often have stronger lobbyists. There's lots of different reasons. I also think that people will complain about their child not getting access to cancer services more than they will face the stigma of having to loudly complain about their child not getting access to behavioral health or substance use disorder services. So I think there's just so many things that I wish our citizens could get more involved with that too. I find the City Council so incredibly compassionate about this. Both you and Councilor McCarthy have held hearings about this before, and so anything that you can do to ask insurance companies to really step up and adequately pay for behavioral health so that more clinicians can stay within networks rather than jumping out would be incredibly appreciated. I think the press publishing more stories on that, the Boston Globe has been really tackling this issue very strongly, although I would love to see more coverage of the actual problem with rates being as low as they are. So whatever you can do will be greatly appreciated.
Thank you, Jen.
Thanks.
Thank you. Councilor McCarthy.
I really don't have any questions, but just thank the three of you. Jen, I always love coming to your shop and seeing you around in Rosendale. And David, it was a pleasure having you a couple weeks ago. And I know that, Steve, you've been in this building many times before. I think that to jump on to what Councilor Asabi George stated, that, the social media is tough. And I know David alluded to being a city councilor. And even, social media is tough on us. An awful lot. And whether it's, if we miss a meeting or it's an attack on our integrity or it's an attack on our thoughts or whatever. And to be on the other side of that as a teenager or a young adult, straight, gay, whatever, I'm sure it wears deeply on them. And that's troublesome. So I think that, I know that I'll certainly continue to produce and my social media aspect of it to make sure people know about it. I know that the wristbands, as you alluded to, do help. Last year, I think you gave out the wristbands last year.
Councilor Presley.
Councilor Presley gave out the wristbands last year, and we wore those for a couple of weeks. And anything we can do to continue to help. And I know that we'll try to do everything we can. I'm looking forward to some of the information about the Thrive program from New York City, and see where we can go as budget season is approaching. Now's the perfect time to make some changes.
If I can chime in.
Here we go.
All right.
So I would ask everyone here before you leave to grab one of these wallet cards with our phone number and a wristband with the mayor's seal as well. Thank you.
No, thank you very much.
And I would just add, I think I speak for all of us, we're so grateful for the opportunity to have this conversation in the light of day in this chamber, in front of the city council, normalizing this conversation, which for so long has been something that many people are reluctant to talk about, is, we believe, one of the first steps that we can take toward finding people who are struggling and saving lives. So thank you for the opportunity.
Well, and we also have many, many viewers at home who watch this. And unfortunately, many viewers who find themselves isolated are also watching this at home. So I hope they use this information to access resources.
Yeah. And as Steve said, I think this is worthwhile to follow up on. When you ask someone directly, I'm worried about you. You're not yourself. You let yourself go. Is everything okay? Are you thinking of hurting yourself? Are you going to commit, take your life? Are you going to, are you thinking of suicide? When you say that to someone, you're not going to give anybody the idea of taking their life. You're going to open up a dialogue and show that you care. You're not going to talk anybody into it. So I think using that word, as you said, are you thinking of suicide, is very, very important. So if you're watching this, just ask.
Thank you.
Thank you.
Thank you all very much for being here. And we do have a few last people for public testimony. I know Lauren Schneider would like to speak, and maybe Eleni Cypress is also here. And anyone else for public testimony, you can get in line just behind them. Thank you, Lauren, for being here.
Thank you. Thank you for having this forum. I think it's so important, and it's
There we go.
That got everybody's
Thank you,
attention.
Nadine.
yeah.
Just tilt that mic towards you. Yep, there you go.
There we go. Thanks, Tim.
This forum. My name is Lauren Snyder. I am a program manager with Boston Medical Center's emergency services team focusing on criminal justice diversion, specifically our police-based part of our program. And so I thank you for your support of our program historically and for giving us a forum today to talk about some ways that we hope in the future to move forward and be able to enhance some of the work that we're already doing and more nuanced ways to meet the needs of the city. My role has historically been one more of leadership and supervisory capacity over the clinicians who are working closely with the police, but I've been able, in part through some of the funding that's come through City Council, to do some of the co-response work myself. And that's really been very helpful to see the police really in action, interfacing with the community in times of crisis. I can do better.
Maybe I'll have you switch, if you don't mind, to the other microphone over here. Thank you. That's why we have two.
All right, let's hope. Oh, is it me that's going to follow me? Okay, so I continue to supervise the clinicians, one of whom is here with us today, and serve in an administrative capacity. And I've also had the opportunity to participate in trainings, both with Boston Police. We're doing more and more to provide co-training with Boston EMS, because we're often arriving on scene to behavioral health crises together with EMS and finding ourselves in a position of joint decision-making sometimes around who can be of best service, and that opportunity has, I think, been beneficial for both of our agencies. We continue to seek opportunities to enhance the training for call takers and police dispatchers and EMS dispatchers and call takers. So these efforts through the sequential intercept mapping that was mentioned earlier have really helped us to illustrate where are some of the gaps so that we can better access people in time of crisis and time of need. Our clinicians who are working with the police, I just wanted to make mention, Dr. Henderson talked about how wonderful it would be if there could be a service like BEST that was not insurance driven, and that can be a barrier. And one of the things that we've been able to offer through the partnership with the police is that any police-based referral to BEST, whether that's coming directly from the police to our 800 number or through the interface with one of our co-responding clinicians in the field, is insurance blind. So whether the person has private insurance, so we may not normally have been able to serve that person, we will do so because of our unique relationship with the police. Our clinicians then have the ability to provide sort of a no wrong door access for any kind of behavioral health services. So from youth to geriatrics, from mental health crises to substance use disorder related crises, we're able to help officers to navigate the complex world of behavioral health services. And we're a city rich with services, but it's not always so easy to navigate. So we appreciate the City Council's support over being able to serve that, what sometimes can be a gap, and to be able to bridge some of that. And I just wanted to reinforce the support that we have for the specialized unit, the special dedicated unit that Deputy Stratton mentioned earlier, that might allow better access to much needed follow-up or proactive services that not every 911 call can be resolved right in the moment that it would be better. Some of those calls illustrate issues that need more follow-up, time for follow-up supports. And so I think that this dedicated unit would be a unique way for officers and clinicians to partner to follow some of these cases that are higher utilizers or more complex, that need a little bit more of that oversight if these are calls that are bringing the police to a family's home repeatedly or to the attention of a particular person struggling on the streets. We're right now pretty much predominantly focused on 911 calls, so this would be really meeting a need that we've identified as well through our years of doing co-response in the city, that if we have a clinician in a car with an officer, then that clinician is not also able to be someplace else at the same time doing that follow-up work. So I think that this dedicated unit would really fit an unmet need in a unique way. I think that those were all the points that I wanted to make. I really just wanted the opportunity to say thank you for the forum and for your ongoing support.
Lauren, thank you very much. Thank you. And then I know Brandy, I saw her back there. And then anyone else for public testimony today? Elsie? Eleni. If you can come up too, we'll give that one a shot. But Brandy, come on, you're already here. You'll be next.
President Campbell in absentia, honorable councilmen, Bostonians, and fellow advocates. My name is Brandy Fluker-Oakley, and I'm the Executive Director of Educators for Excellence Boston, a teacher-led nonprofit that works to elevate teacher voices in the policymaking process. Thank you for providing me with the opportunity to speak to you again this morning about the need for more mental health support staff in our schools. In past testimony, I have shared how unaddressed trauma can impact students' learning, affecting their memory, organizational skills, and comprehension. However, today, I want to speak about this issue specifically through the lens of suicide prevention. When thinking about individuals who are susceptible to attempting suicide, there are some prototypes that emerge. One are those who express their depression and hopelessness outwardly, and the others are those who present a facade, keeping their suffering silent. It is people in the latter prototype who are most likely to fall through the cracks, a fact I know because I was almost one of them. On the surface, I appeared to have it all together. I was attaining a post-secondary degree, being exposed to numerous professional opportunities, physically healthy, and achieving a level of success in my life that would lead outsiders to believe that I was thriving. However, that was not the case internally. My thoughts towards myself and other life happenstances were chipping away at me. The weight of my internal world had become too much. What my struggle has taught me is the importance of strong, trusting relationships. I was lucky. I had built a relationship with an employee at the university that I attended, and thus I had someone I trusted. When I was at my lowest point, she asked me how my weekend was. I could have let this otherwise innocuous question pass by without revealing my inner emotions, without telling her what I had really been up to that weekend, writing a letter to my family and friends with a bottle of bleach by my bedside. But because we had built that trust, I was able to confide in her my moment of need. She pointed me in the direction of counseling services, and I'm only here today because of that trusting relationship and access to experts. Right now, in our schools throughout the city of Boston, the Commonwealth of Massachusetts, many students have neither trusting relationships, like the one I had, nor access to mental health experts who are trained to identify the signs and risk factors and who can provide the support needed to help someone like me. Beyond not having the adequate number of mental health support staff to meet the recommended ratios, many psychologists, social workers, and counselors serve multiple schools. This makes it incredibly difficult to build trust and relationships with at-risk students and to provide the services that they need. As my colleague Jake shared earlier, our teachers have spoken out about the importance of teachers establishing trusting and building relationships with students. These trusting relationships ensure that students feel that there is someone they can confide in when a suicidal thought occurs, just as I was able to. Our teachers have also highlighted the need for mental health support staff and that those be permanent in the building. This ensures there is someone else in the school who will build a relationship with students and counsel them. I applaud you so very much from the bottom of my heart for raising this issue, for helping to eradicate the stigma, for giving me an opportunity to share my story, and I look forward to this conversation resulting in action that will better serve our students and families here in Boston and throughout the Commonwealth. Thank you so much for your time.
Randy, thank you. Thank you for sharing your story with us today. Eleni. We're gonna, Laney, we'll have you just move over to that one. That one, I think, has been turned off permanently, at least for today.
I haven't really prepared for this, but just listening to everybody speak, I can tell you a little bit about myself. I'm sorry, I have gotten quite a bit of training in domestic violence. I have had the opportunity to work in a shelters and volunteer. Also, I'm volunteering with BARC, which is the Sexual Assault Center. And I've worked at Shelter Teenage Pregnancy. By father, I have grown up with a father that has, I didn't know growing up, but mental illness. He had PTSD as a child. He grew up during the war. This is when he called it the Gestapo. That was in Greece. Would torment the family, terrorize. So as an adult, he had just a very, the temper, my mom, very abused, emotionally, not physically. But it's very traumatic for a child to have to witness that. And I grew up having the needs to protect my mother and to take care of her and to keep peace in the family. I had difficulties in school. I ended up, at some point, I wish there were ways that there was help for the family. So when you see a child struggling, the child really is just a reflection of what's going on at home. And unless the entire family is somehow addressed, it's more like just a Band-Aid. Also, I think it's very important, the thing that helped me, when I got the training in domestic violence, I was at that time, for many, many reasons, I was homeless, but I did not know I was homeless. In Virginia, the definition of homeless is not having a home. Going from home to home, having a place to sleep, a couch, does not consider, is homeless. So that brought an awareness, and also it normalized, because at that point I felt like there's something wrong with me. I had also been through domestic violence. I had developed PTSD, which I didn't understand. And I didn't know that my running was a result of what I had gone through. And so getting that education made me feel like, okay, so there's nothing, it's not me, that it's a result of something, and therefore it can be fixed. I feel like it's important, this education, to be done at the elementary school, at the elementary level. So children can they're very intelligent, they can get an understanding, and they can bring that information home to their parents. I also learned the word hypervigilant through my training, and I understood myself. There's just a lot. I mean, it's like trauma. Once you're in it, it just follows you one right after the other. And I couldn't possibly state everything, but my daughter ended up also, it's a family thing. My daughter ended up opiate addiction. She had been traumatized from over and over. And I'm so grateful to Boston Medical Center, saved my daughter's life. But also, again, I think the importance of family needs to be emphasized, because I went begging, I needed to understand how to help my daughter. And I was pushed away like I was a monster, but I didn't understand that my fear of trying to save her is actually traumatizing, but I needed to be part of that. I needed to be explained, like, how can I help? What am I doing wrong? You know, because I'm just as much a part of that addiction, my whole family. My mom, after 54 years, my father is now in a psychiatric, but she's finally, after 54 years, left him because she finally feared for her life. She thought she was going to be able to save him. People that are in domestic violence situations, they don't come up, they don't ask for help because they feel like they can take care of the situation. And it would be great if people can, if the system could somehow come in and say, you know what, you cannot handle this. We got this, and this is what we're going to do, and take it out of their hands. Thank you.
Eleni, thank you very much. And again, just thank you, everybody. I want to close just because I think it's the one of the more the comment that sort of stretched all of our conversations today. And I refer again to Dr. Bradley's notes, but just the work that we're doing across all of our different responsibilities and sort of sectors within this industry is that making sure that people are well integrated into support systems, that they're able to achieve financial and occupational stability within those communities, to really limit their risk of maladjustment, substance use disorders, and ultimately the possibility of suicide. It's really important that we continue to consider this when we think about our work as a whole. I do want to have just a special thank you to Nadine, Jean, and Megan Camillo in my office for their work of putting today together, as well as our suicide prevention recognition that we did about a month ago. Councilor McCarthy, thank you for being with us, and of course, central staff. This was a longer than usual hearing, and I appreciate everyone's certain patience and attention to the important work that we're trying to undertake. Councilor McCarthy.
I'm good. I just, thanks very much. I'm sorry I was late, but I had a thing in this morning I had to get in. But I got in as fast as I could. I saw Jen, so now I'm covered. I'm covered. But I think, you know, just a promise to everybody who's watching and a promise to the three panels that have been before us is that we'll continue to strive forward to try to get something taken care of. Because, you know, we talked about at lunch with David, you know, my son plays football, and a kid in his team killed him, you know, took his own life this year, and you know, it can hit home. So we'll continue to work as hard as we can on it.
Thank you. Thank you all. This meeting's adjourned.